I didn't come back to work, but I was like, I look. So fun. I'm not that fun.
Okay. All right, is this recording? I'm just gonna make sure. Okay. All right, Lord, here we go. Kidneys and urinary tract, okay? For this exam, because I realized I must have not put it on the syllabus. For this exam, chapters in ATI, you need chapters 43 through 45, and also all of Unit 8, and also chapter 65 and 66, but only in 66, you only need to read about BPH, and in 65, the TERP procedure, okay? I didn't realize those were not in the urinary chapters. So BPH and the TERP procedure are just in those 65, 66. It's not that much. Okay. So kidneys, what do? If you know what the organs do, it'll be easier to figure out what happens when they don't do what they're supposed to do. So the kidneys, they regulate electrolytes through reabsorption and excretion of fluids and electrolytes, right? They regulate acid base. How do they regulate acid base? Does anybody know?
Getting rid of the ions, like the bicarb or like the hydrogen.
Yep. So they excrete hydrogen or they hold on to bicarb. And that will determine, that helps balance out acids and base. They metabolize drugs, obviously, and they regulate the blood pressure. They regulate blood pressure via that renin, angiotensin, aldosterone system. Everybody remember that from pharmacology? Probably not. But basically the kidneys make renin, it gets converted into angiotensin 1, then 2. Those will cause vasoconstriction. And what will aldosterone? Aldosterone will be secreted from what gland? Adrenal gland, yep, which are right on top of the kidneys. And what does aldosterone do? Water and which electrolyte? Sodium. So aldosterone gets released, the body holds on to salt and water because they go together. So what's that going to do to my blood pressure? Go high, right? So anything that's going to cause high levels of aldosterone is going to cause high levels of what? Sodium, and high level or fluid overload. So just think about that, high aldosterone. Cushing's, when we get to endocrine, Cushing's causes hyperaldosteronism. So people with Cushing's have high sodium, high blood pressure. All right, the other thing kidneys do, they secrete erythropoietin. Erythropoietin aids in the production of red blood cells. So if my kidneys are failing, what's my red blood cell count going to be? Low. So if I have kidney failure, I have probably anemia. Chronic kidney disease causes chronic anemia. The other chronic thing chronic kidney disease causes is a low calcium. It converts vitamin D into the active form so calcium can be absorbed. So if my kidneys are failing, I cannot absorb calcium and my calcium is going to be low. If my kidneys are failing and my calcium is low, what do you think my phosphorus will be? High. They have an inverse relationship, calcium and phosphorus. If calcium's down, phosphorus is up, and vice versa. Got that? All right. Now, you are not going to school to be a nephrologist. So you don't need to know, when you study for exams, you just need to know a basic pathophysiology. You do need to know a basic what's going on with the body. Down to a cellular, molecular, DNA type of level, no. You're not Bill Nye the Science Guy. You just need to have a general idea of what's going on. Having a general idea of what's going on will help you figure out what the symptoms and things would be or what could be causing it. So basically, you don't take notes on this. I'm just trying to show you how the kidneys work. Because if you know how they work, then the diseases will make sense. So don't take notes on this. Don't get obsessed trying to learn all about glomerular filtration. Please don't waste your time. But what are the kidneys? They're bean-shaped organs. They lie in the retroperitoneum. We learned about the peritoneal cavity. That's where all the abdominal organs are. The retroperitoneum is going to be behind that, right? So that's why when people have kidney issues, they have flank pain, right? Each kidney has multiple lobes, blah, blah, blah. But anyway, the basic functional unit of the kidney is this whole unit, the nephron. This is one nephron. Your kidneys have millions and millions of nephrons, okay? So through the nephrons, blood flows in. Blood flows into this glomerulus. It's filtered, and then it goes through the tubule system where water and electrolytes are either excreted or absorbed, okay? If you look at the tubule system, it looks almost all twisted up like the small bowels, small intestines. The small intestines are responsible for absorbing water and electrolytes. The tubule system of the nephron is responsible for absorbing fluid and electrolytes. So that's why when you take loop diuretics, which work right here on the loop of Henle, you end up with fluid and electrolyte loss, right? Real quick, just a video on just seeing how that blood is flowing through the kidneys. Oh, is there sound? Huh. Hold up. Pause, lady. Hold up, lady. All right.
You and Charlie too happy about that.
What's up? I'm gonna put a new one. I'll put a new one up because I don't know how I did that. Okay.
Glomerular filtration. Kidneys are bean-shaped organs which filters blood. It removes waste substances from the blood and regulates water and electrolyte concentrations within the body fluids. The end product of this function is urine, which is excreted outside of the body through urethra, containing wastes, excess water, and excess electrolytes. Urine formation involves glomerular filtration, tubular reabsorption, and tubular secretion. The nephron is kidney's functional unit. At the beginning of the nephron, the glomerulus is a network, tuft of capillaries that performs the first step of filtering the blood. The glomerulus is encased in thin, double-walled capsules called Bowman's capsule. The space inside the capsule and surrounding the glomerulus is called Bowman's space. As the blood travels through these capillaries of glomerulus, filtration causes a lot of plasma contents to spill out into Bowman's space through the glomerular filtration membrane. It consists of 3 layers of capillary valve: endothelium, basement membrane, and epithelial podocytes. This membrane allows some particles of blood to pass through, but not all.
All right.
Mhm.
So that's all I needed you to see, right? So, because as I go on and talk about these diseases, it will make more sense. Take me to the next one. All right. So when we're looking at kidney function, here's the labs we're reviewing. Urinalysis. Urinalysis. You can collect it multiple different ways. You can get just a random urine, you can get a clean catch, you can do a sterile catheter insertion, or drawing it from a port of a catheter that's already been inserted. But you have to know, what am I collecting the urine for? So why might I collect a random urine? Drug screen, looking at medication levels, even looking at electrolytes. You might collect a random sodium or something like that. Not you, but you won't order it. You just collect the pee. But the nephrologist, a kidney specialist, might order random. Random should only be used if I'm not looking for what?
True.
Infection. If I'm looking for infection anywhere, any type of culture, if I'm doing a wound culture, I don't just pull your Band-Aid off and get a wound culture. I have to clean the wound first because it could be contaminated, right? There's bacteria everywhere in the world, on our skin, everywhere. So if I don't clean the area first, my culture is going to be contaminated. What else? When else should I not get a culture? If I'm already on antibiotics. If I've already started antibiotics, there is no point in getting a culture. It's going to change the results. So you have to collect a culture prior to starting any antibiotics. And that's any culture: urine culture, sputum culture, blood culture, wound culture. Any culture is going to be, it needs to be collected sterilely to make sure you don't throw off the results, and you have to have not been taking any antibiotics, usually for 48 hours, to make sure the result is accurate. So I can get a culture through a clean catch. Everybody know how to perform a clean catch?
Yeah.
Tell me how to do it then, since you know so much. No,
You wipe first.
wipe first.
You stuff
Do men wipe first too?
Yeah.
Yes, wipe first. If you're a man, like, oh, what am I supposed to do? Wipe your penis, sir. Just wipe. Wipe around the urethra. Yeah, wipe, circular motion. Just wipe.
Wipe it off.
And then what do you do?
You stuff it.
You start the start, you
Stop.
stop it, and then you
Yeah.
get it in the.
Midstream. Because even if I didn't wipe good enough, if I pee a little bit, hopefully that will get the rest of whatever little contamination was there. And then I could get a nice, good, sterile specimen. I'm pretty sure you guys already know about inserting a Foley catheter, right? You did that at some point in school, no?
Yeah, lots of
Skills lab or something? Okay, so that's a sterile procedure. So here's a tricky question. A lot of the questions on the exit and on NCLEX have to do with delegation. Can I delegate to a CNA to collect urine from a Foley catheter?
Yes.
The answer is actually no. So for the purpose of exams, if you need a sterile, if you need a random urine that they're just gonna get out of the bag or whatever, fine, but I never recommend getting urine out of the Foley bag. That urine's been sitting there all day, okay? All damn day, all day. Everything, dust and particles are settled all at the bottom. It's gonna be inaccurate. The acidity, the pH of your urine, the longer it sits, it becomes more alkaline. Alkaline substances are going to collect bacteria. Now, everybody's gonna say, well, I get urine all the time at my job. Of course you do. Who wouldn't? I'm not, if I'm an RN and I got a CNA, I got time to go collect it. Go get the urine. But for the sake of delegation in nursing, a sterile procedure cannot be delegated to an assistive personnel like a CNA. Anything that involves sterility, it cannot be delegated. So getting it from that port in the catheter, you could delegate it to an LPN, but you could not delegate that to a CNA. Now, I know, Jenny, you're gonna say, I do it all the time, right? That's what you're gonna say?
Yeah. But
Yeah.
I have a question. They say like within a certain amount of minutes, you can't send out the urine in a certain, it has to be a certain time frame. Like when they, like I tell my patients, when you are done, call me right away so I can send
Oh,
you.
yeah, because urine, the longer it sits out, bacteria is natural. If you leave your water bottle uncapped, sitting on the desk right now, as hours go on, all types of stuff's gonna collect on there. Bacteria loves moisture, bacteria loves heat, bacteria loves dark places. So urine will like too, either, it depends on what type of bacteria, urine, as the longer it sits, it's gonna change pH and more bacteria and things are gonna collect. It's gonna throw off the result. So what about when you get a 24-hour urine?
Keep it on ice.
Yeah, or if they're at home in a refrigerator, if you nasty like that, you put pee in your refrigerator. But me personally, if you're at my house getting a 24-hour urine, you better get it cooler. You better get up, don't put that in my refrigerator. But you know, at the job, they have a pee refrigerator. At the lab, they have a pee refrigerator, a poop refrigerator, they got all types of stuff. But a urine, it has, once, like she said, once it's collected, it's gotta either go in the refrigerator or go straight to the lab to maintain its, whatever, stability. I don't know. All right, urine results, when I look at them, all those results should be negative. Anything outside of that is abnormal. Now, don't get me wrong. We all have bacteria and skin cells that live on our skin. So 99.9% of the time, you're probably gonna have white blood cells or red blood cells. These 4 should always be negative. You should never have glucose in your urine. You should never have protein in your urine. Never have ketones in your urine. And your positive nitrites is guaranteed UTI.
Can I ask you a question?
What's up?
The ketone thing, don't people, this has nothing to do with nothing, but don't they try to, what is it with the ketones and like?
Ketones are a chemical released by the liver when there's not enough insulin to break down carbohydrates. So if you don't have enough insulin, then your body is going to release ketones if you have a lot of carbs circulating. But now they got this keto diet. What the keto diet does, you're eating no carbs. So insulin only breaks down carbs. So if I'm not eating any carbs, then I need something else to break down all this protein and fat. So then you send your liver into ketosis. That's not good for your body, okay? Any of these fad diets are not good for your body. Exercise and eat a balanced meal. The food pyramid been the same food pyramid since 1932 or whenever they came up with that thing. It hasn't changed. Eat less than what you exert and you will lose weight. Do not restrict yourself. You need carbohydrates. You need some fat. Not all fat diet either. My patients I've had on a keto diet, they lose so much weight. And then they need cholesterol medication because their cholesterol is sky high because all they've done is ate fat for 6 months. Yeah, you look good, girl, but you better have a damn heart attack. You better have pancreatitis. You look real nice though. But I bet you have a chest pain, all that doggone fat you ate. All right, glucose and protein. I'll show you that later, but those are too big to pass through that basement membrane like the lady just showed you in the kidneys. It's like trying, let's say that basement membrane, that semi-permeable membrane, say it's like a screen on a window screen, and you trying to shove big old boulders through the screen. It's gonna tear your screen up. So trying to force protein and glucose through your capillaries, those tiny little blood vessels that are all over our organs, through your kidneys, protein and glucose are going to tear them up. So then you end up with organ damage. You end up with poor circulation. You end up with renal failure because protein and glucose is too big to be passed through any of these places. So when you have high levels of protein or high levels of glucose is gonna cause that, and we'll talk about it more in a minute. Culture sensitivity, we already talked about, and specific gravity. You need to know that for the test. What would it mean if my specific gravity is up? Of my urine. My urine specific gravity is high, so my urine is what? Concentrated, right. So what? Dehydration. What else might cause my urine to be concentrated? Hypernatremia. What else? What about ADH? What if I have SIADH? What happens with SIADH? What? You're retaining water and you're excreting what? Yes, so your urine's going to be concentrated. You're excreting mostly sodium and holding on to only water. So your urine's going to be very concentrated, not enough water coming out, just thick, concentrated urine. And then if it's low, what does that mean? It's diluted. So what kind of things will cause my urine to be diluted? Yeah, fluid volume excess. So anything that will cause my urine to be watered down, then my urine specific gravity, or if I'm getting rid of only water, less than electrolytes, my specific gravity is going to be low. And if it's more concentrated, it's going to be high. Now, when we look at blood tests, the creatinine, urea, uric acid, all of those things are waste products from the breakdown of protein. Waste products from the breakdown of protein. So if there's something wrong with my kidneys, then that waste is going to build up and my labs are going to be high. BUN will be high, creatinine will be high, and uric acid will be high in renal failure. What about my GFR? Nobody read? Is it going to be high or low in renal failure? Low. What you just watched that video was the glomerulus, remember, filters the blood. So the rate that it is filtering should be as high as possible if my kidneys are filtering properly. Even though for us as nurses, we look at creatinine, right? Creatinine is the most kidney specific, that's what we look at. Nephrologists, when they determine what stage of kidney failure you're in, it's based off your GFR. This is actually the most accurate determination of your kidney function. So what's end-stage renal disease? Less than 15. If my GFR is less than 15, I need dialysis. My kidneys don't work effectively at all. And I'm not going to be able to filter waste out of my blood. What were we going to say, Jenny? That was it? Yeah. So less than 15. Now, here's the thing. You want to talk about health disparity. Who do you think, what race do you think is more likely to get diabetes?
African American.
Whites. Whites are more likely to get diabetes. More white people have diabetes. Who's more likely to die from diabetes?
Chocolate people.
African Americans. Who's more likely to have dialysis? African Americans. African Americans are going to have worse outcomes than whites when it comes to diabetes. So when you talk about eliminating health disparity, it starts with prevention and education. There needs to be more education in the African American community on how serious high blood pressure and diabetes are. When you don't know better, you won't do better. So if everyone in my family has hypertension and they seem straight, everybody looks straight, we're doing all right, we're living, they don't know. Hypertension is called what?
The silent
killer. It's a silent killer. Because by the time you have symptoms, you're already having end-stage organ death. So, saying, well, I don't take my medicine, I feel fine. Okay, all right. My friend's husband died at age 41 last year. He was not fat, he wasn't overweight, but he had hypertension and he felt fine. And he had a hemorrhagic stroke at the age of 41. When I worked in the ER, I seen a police officer, 32, good shape, body looked good. Doesn't matter what's going on the outside. If you have hypertension, it's killing you on the inside. And he died at 32 of a hemorrhagic stroke. So Hypertension is a silent killer. But anyway, I say that because GFR levels, if you ever look at the labs, look at somebody's labs. The GFR is going to say non-African American and African American. They calculate the number differently. The threshold is a little bit lower for African Americans versus other races. What's up?
So you said less than 15 is renal failure?
Yes, that's ESRD, end-stage renal disease. That's stage 5 chronic renal failure.
But that's over 3 months, right?
Over 3
It
months?
has to be consistent for 3 months.
They have to have.
Oh, yeah, like you could be in acute renal failure and have a low GFR. Yeah, but for 3 months, if you have chronic renal failure, it's gonna gradually keep going down, keep going down. Your doctor's gonna watch you. We're preparing. By the time you're at stage 4, they're probably already gonna say, we're gonna start getting you a surgery for a fistula. Because you probably don't need it now, but in 6 months, you'll probably be on dialysis. So, yeah, it is. Yeah, it's not like, oh, one day my GFR was low. I'm sorry. So, yeah, thanks for clarifying that. So, yeah, next time you're at the hospital, look at somebody's BMP or CMP. Those labs, you will see the GFR. There's going to be 2 results. It will say African American or non-African American. You got to figure out what one your patient is and then pick which result is theirs. If they're African American, then pick that other result. And you'll see for a non-African American, their number is going to be lower than they give them a little bit more leeway. Uric acid builds up because that's a waste product, and a high uric acid causes urate crystals to form, and that is what gout is. Gout. Gout's not going to be on this test. I'm just trying to show you how the whole body works together, people. All right, to look at a kidney, we're going to look at x-ray first, or ultrasound, least invasive. So those things, KUB looks at the kidney, ureter, bladder, and then renal ultrasound. Both of those will look at shape, position, but they're not going to show blood vessels. Versus IV pyelogram or angiogram, that's looking at circulation in the kidneys. For the exam, for any exam, you need to know about giving a patient a test with IV contrast. What kind of things do I need to know if you're getting IV contrast? Allergies. Allergy to shellfish, allergy to IV contrast, allergy to iodine. Any of those, we're probably not going to give you IV contrast. What else do you need to get IV contrast? You need decent renal function. If your kidneys are failing, I can't be giving you IV contrast. Or if you're in real renal, if you're a dialysis patient, you have more leeway, because then I could give you contrast and I could dialyze it out of you. But if you're like stage 3 kidney failure, I don't want to put you in stage 4, stage 5. You have to have to watch. When a patient goes to CAT scan, if they don't have any labs, the CAT scan tech or whoever, they're going to call you and say, I need a creatinine. They'll call the doctor and say, I'm not going to do the test until you give me a creatinine. Some hospitals, they have like a machine that can poke your finger, but you have to know renal function and allergies. So that's the main thing. And then if they are on metformin, no matter what, if they're getting IV contrast for anything, whether it is cardiac catheterization, whether it's a CAT scan of the belly, a CAT scan of the chest, IV, anytime you get IV contrast, if taking metformin, it must be held for 48 hours following the procedure, because it will put you at even higher risk for kidney failure after receiving the diet and lactic acidosis, a form of, what's lactic acidosis? Metabolic acidosis. It's a form of metabolic acidosis, lactic acidosis. And then just another side note, anybody ever had CAT scan with IV doc? How'd you feel? Feel immediately like you peed on yourself. I don't know why. I don't know why it does that. It just gets real hot. No matter what kind of scan you're getting, they can be scanning your brain. But as soon as they inject the IV dye, you gotta tell the patient, you're gonna feel like you peed. Okay? And I got a CAT scan when I was like 20, and it was a scan in my chest, and I was like, oh shit, I did pee myself, because that's how bad it feels. It just instantly, it's like some warmth just creeps around right here, and you're like, hey man, this is myself. Like, oh my god. And that's just any IV dye. So with the angiogram, a renal angiogram, you're looking at arteries. Any type of angiogram, you're looking at blood flow through the arteries. So whether it's a coronary angiogram, which is a cardiac catheterization, whether it's a angiogram, I don't know, your carotids of your legs, anything. Angiogram means artery. IV dye is going to be injected this time, not into your vein, but to your artery. So like for a cardiac cath or for a renal angiogram, they put the catheter in your femoral artery or your brachial artery. Sometimes they use like a radial artery, but it's in an artery. It's going to look at how blood is flowing to the kidney. Same, all the rest, besides the word angiogram being artery, same precautions as the other one. IV dye, allergy, need to know kidney function, gonna make you feel like you peed on yourself, all that. And then if they go in your femoral artery, usually you need to be on bed rest for at least 8 hours after. Cystoscopy. Sorry to get so graphic, but I didn't know if you guys knew what the lithotomy position was. Cystoscopy, they go in, it's just like endoscopy. We're going when they're looking in the colon, when they're looking in the esophagus. Well, now they're going through your urethra and they're looking in your bladder. So same kind of precautions as those other ones. You're gonna probably get either moderate sedation or even, depending on what they're doing, they may get general anesthesia. So you have to think about that when they come out of the procedure. They just got anesthesia. I gotta monitor their oxygen. I gotta make sure they got a gag reflex, all that good stuff. This one, because you've been laying spread eagle like this for however many hours or minutes or how long, they may have some leg cramping when they come out of it. The lithotomy position after so long can be tired, laying on the bed like that. Also, you're going to monitor, now they've gone in with the camera in the urethra, your bladder, your urethra, this whole area, very vascular. So they may have some blood-tinged urine after a cystoscopy and after a TURP. It's expected. They're going to have a little bit of bleeding after that procedure. What is not expected is what you saw with the esophageal varices. That would be bright red, dark burgundy, blood clots, all that. If you see that coming out, that's not normal. And you need to notify the urologist or something. Sometimes you could see clots and you may just need to irrigate. That's another option. If there is an order and the bleeding is expected, the urologist will say, okay, every 3 hours, you can irrigate with sterile water or sterile saline. Anything going into the bladder must be sterile. GI, not sterile. People put dirty hands in their mouth all day long. Lungs and bladder must be sterile at all times. And remember, anything sterile for your exit, for your other exams, cannot be delegated to a CNA, no matter what it is, even if you do it every day at work. If it says sterile, it can't go to the AP, assistant personnel. And then after anything that they inject dye, you're gonna push fluids. They need to pee it out. And if they swallow dye in their GI tract, then they need to poop it out. Give them a laxative so they can get that dye out of it. Catheter insertion, we already talked about that. Just, maintain good hygiene down there. What are you gonna do if you see a Foley catheter and there's no output? Check for kinks, check for loops. Make sure it's not laying on the patient's 500 pounds and their big old thigh is occluding it. The first thing you're gonna do is check for kinks. So when you get questions like that, oh, there's no output from Foley catheter, don't call the doctor. Calm down, all right? Do some problem solving first, all right? Don't call the doctor. Only time you call the doctor is in a critical emergency. If it's something that it's outside of my scope of practice to even fix this, call the doctor. Other than that, look for kinks, look for loops, that kind of stuff. Why? Because I've seen that test question multiple times as well. Age-related consideration, obviously we get old, stuff just slows down. Their GFR goes down a little bit. Their blood flow goes down, everything goes down. They're old. They also have a decrease, their urine tends to be more diluted. They're not able to concentrate their urine as good. They're at higher risk for fluid and electrolyte imbalances. And then older men, they have enlarged prostate issues. Women, they start getting incontinence, bladder drops, things change down there. Now, UTI. Who's at higher risk for UTI, ladies?
Older
Us, right? Us, females, older adults. Who else? What about people that wear diapers? Doesn't matter what age you are. You wear diapers, you poop in your pants, you're gonna be at high risk for a UTI, right? If you out here, working that corner, throwing that cat, around no facility, you might be at high risk for a UTI, right? What about nobody, you didn't have a mom, you grew up with a dad. Dad taught you how to wipe from back to front. It's bad for business. You're probably gonna get a UTI. You gotta wipe front to the back, right? And anything that causes urine to sit still. So remember, like if I leave a bottle of water out stagnant, bacteria is gonna collapse. So anything, so whether it's I have BPH and it's obstructing the outflow of urine, or if I'm paralyzed from the waist down, or maybe the chest down or whatever, and I have a neurogenic bladder and I can't make myself go to the bathroom, anything that's gonna make urine sit still in the bladder or in the body somewhere is gonna put me at risk for UTI. Now, just like when we get to respiratory, there's lower UTI and there's upper UTI. So a lower UTI is gonna be in the bladder, right? Cystitis. Oh, but I didn't get to that yet. Anyway, no matter where it's at, the symptoms are usually the same. They just get more severe as it gets into the kidneys. But the symptom, dysuria, burning when you pee, bacteria in the urine, nitrites. Nitrites are only positive in a UTI. What's up? Oh, you're saying time out.
Oh, no.
Nitrites. Nitrites are only positive with UTI. A lot of doctors won't even give you antibiotics unless the urine has positive nitrites. Leukocyte esterase, bacteria, all those things are signs of infection in the urine test. Now, what about blood? They may have elevated white blood cells with the left shift, like we learned about, an infection. They may not. If you just have a little bladder infection, you could just drink some water and cranberry juice and essentially flush it out. You may not get so sick that you have elevated white blood cells. But if you have like urosepsis and now it's gotten in your bloodstream, you may have positive blood culture. And then if it gets really bad, it may impair your kidneys. Not every single UTI is going to do that, right? Everybody in this room, I'm pretty sure it's have at least one UTI in their life. If you haven't, good for you, girl. You got that $1 million. We've had UTIs, sorry, especially if you've been pregnant. Pregnancy puts you at high risk for UTIs. I think that's probably the first time I had one was when I was pregnant. But anyway, you're not always gonna have these. These are gonna be a sign that the infection, stuff's gotten real, all right? Now, I'll put this up here. If somebody's exhibiting signs and symptoms of a UTI, you gotta also look at this person. Like, if they're 22 and they're having signs and symptoms of a UTI, you gotta rule out STDs. A lot of STDs, the signs and symptoms are gonna mimic a UTI. Chlamydia, gonorrhea, those things are gonna cause burning when you pee or irritation down there. You got a vaginal yeast infection long enough, that irritation is gonna cause burning when you pee. Herpes, you can get herpetic lesions inside your urethra. So you have to rule out, I'm not saying every old person with a UTI been knocking the boots at the nursing home, but you have to look at your patient and decide, they do them, they really do. They're horrible. But you have to decide, what will be appropriate. So that may come up on an exam. You have a 17-year-old, they're presenting with UTI. What kind of test would you expect? You might expect an STD screen. You can screen urine for STDs. But you can also do the full-on, swab and things. As a nurse, what am I gonna do? I'm gonna give antibiotics. I'm gonna collect these specimens. Obviously, if I need to do a culture, it's gonna be what? Sterile. I'm gonna collect sterile. I'm not gonna collect a random urine to screen for UTI. I'm gonna give antibiotics. Sulfa drugs are the drug of choice. Sulfonamide. So Bactrim usually is the drug of choice. Then there's Cipro and fluoroquinolones, which doctors do tend to use more commonly, but there's a lot of adverse effects to taking fluoroquinolones. So you need to know antibiotics. The thing with fluoroquinolones, Levaquin, Cipro, those should be reserved for more, especially Levaquin, more intense infections. And the big thing with them, they could cause tendonitis. They can cause your Achilles tendon to rupture from just taking that antibiotic. So you have to be mindful of that. Sulfa, both drugs cause sensitivity to the skin. Sulfa, which is Bactrim, can also cause kidney impairment. So you have to tell people to drink a lot of water. Pyridium, everybody know about pyridium? It's also called AZO at Walgreens, AZO, whatever they call it. What does that do? It doesn't clean nothing. It treats pain. It's an analgesic. It treats the pain in your bladder. So the pain associated, the dysuria, it is not an antibiotic. It does not eliminate a UTI, but your body can eliminate a UTI. And drink a lot of water. And then azo or pyridium, you can take that for 3 days to help with the pain. What does it do though? When you take it, what's your pee look like? Orange, bright orange, okay? So that's an exam question a lot of times on NCLEX is that orange urine. Obviously, tonight we go home, ladies, boy, before and after sex, okay? I know some people don't know that, before and after, okay? That's gonna reduce your risk. Wipe from the front to the back, okay? Front to back, remember that. And, don't hold it. Don't be like the rest of these nurses and get that nurse bladder. When I was in med surg, I just graduated college. I was like, oh, I don't want to be like these ladies because like 3 ladies on my floor had their bladder lifted. I'm like, what's wrong with these old loose women on this floor? But they say it's from nursing. You work 12 hours, you hold it all day long. Then you're getting older. You're a woman. You've had kids. Things start to drop. Yeah, next thing you know, they start having that urge incontinence, stressing, kind of got to wear the, what the pads women wear? Poise pads. Yeah, poise pads. Yeah, I was like, God, is that what it does to me, nursing? I don't want that. I don't want that. All right, but what could you do to help with that? Kegels. And when we get to it, no, I took Lamont. Yeah, they taught us go pee and then hold it a little bit. Count to 10 if you can. I don't know about that, but yeah. Anyway, risk factors. I mean, we already talked about that. It's the same for every UTI. The risk factors are going to be the same. Manifestations going to be the same. Frequency, feeling like I got to run to the bathroom often, but then I'm only putting out a little bit. That's frequency. Putting out, a little bit of 30 mLs, and then 30 minutes later, I got to run back to the bathroom. Urgency, feeling like I got to run to the bathroom. It's an urgent matter. Hematuria, blood in the urine. For cystitis, they're going to have pain in the bladder versus pyelonephritis. When it gets higher, they're going to have more flank pain. You could have flank pain with cystitis, but you shouldn't because the inflammation should really just be down. It shouldn't have gotten up to that level yet. They may have fever, they may have chills, but that's a pretty bad bladder infection if you do. Babies are going to be irritable. They're going to not want to eat or drink. Children may, kids, everything make them throw up. Strep throat, throwing up. Everything, throwing up. Nausea, vomiting, abdominal, and back pain. And they may wet the bed. Enuresis. Geriatrics, them old people get confused so easily. Any infection is when you have new onset confusion, or even when you have someone with dementia, but now they're acting crazy as hell. They're beating you up. It's usually an infection. So you always, if you work in a nursing home or you work with a high geriatric population and your patient starts acting crazy, first, or if they come to the emergency room from nursing home, they done stabbed the nurse. What happened? Check your urine. Check your urine. Granny done got a UTI again. She's out here cutting folks. All right, pyelonephritis. So that's upper UTI. That's in the kidneys. Pyelo means pus. Nephro means kidney. Itis means inflammation. Infection and inflammation of the kidneys. So when I say, when you're studying for the exams, you're not Bill Nye the science guy, okay? Nobody's expecting you to go out on the floor and do an autopsy, all right? You need about 1 to 2 sentences on pathophysiology. I think some people get so obsessed studying the actual disease that you're not studying the care. Nursing is an art and a science. The science is knowing the disease, but a major part of nursing, what sets us aside and makes us the elite group, is that art of caring. You need to know the nursing care more for the disease. Let the doctor be focused on diagnosis. That's what doctors do. They don't treat humans, they treat diseases. We treat humans. So when it comes to these exams, don't spend 3 weeks studying diseases. You need to study the signs and symptoms. What is that person going to look like with the disease? And what can I do for that person? So maybe that will help, because I know some people get so obsessed with studying pathophysiology. And I just keep saying, you only need to know that because it helps you understand what you're doing as a nurse. But nobody expects you, like I said, to perform no damn autopsy at the end of nursing school. Pyelonephritis, same risk factors, going to be women, girls, whatever, old people. But the only thing is, chronic infection, chronic inflammation is going to lead to organ failure. So if you are constantly getting UTIs, constantly getting pyelonephritis, eventually it can lead to chronic kidney disease. We'll talk about acute renal failure in a minute, which we'll talk about these different things. But basically, I would think these risk factors are self-explanatory, right? Manifestations are the same. The only thing is now their manifestations are gonna be more dramatic. They likely are gonna have fever, chills, nausea, vomiting, flank pain. This, to me, when you're assessing the kidney, I'm gonna be honest, that's the only time I use percussion. I never percussed anything since nursing school, except for checking for CVA tenderness, costal vertebral angle tenderness. That angle from where your ribs go down away, your last rib from your spinal cord, that's where your kidneys are. So checking for CVA tenderness, I put my hand and I hit with my fist. If a person has pyelonephritis or a kidney stone, they're gonna jump up, they're gonna punch you in the face. They're gonna jump off the table, usually, if something's going on in the kidney and you percuss when the kidney's inflamed. So that's how that's one of the classic symptoms, is that CVA tenderness. All of them is gonna be the same, giving IV antibiotics or PO antibiotics, giving fluids and everything. I mean, it's the same. It's an infection. Treat the infection, push fluids. Those are all the same. Glomerulonephritis. So remember the glomerulus from the video. I don't know how the lady pronounced it, and I don't even know if I'm pronouncing it properly, but you know what I'm talking about. It's where all the filtering is occurring in those little nephrons. So for some reason, they become inflamed or they're not doing their job anymore. Usually, if it's acute, it's usually an infection. Usually a strep A infection like strep throat. You could have a streptococcal skin infection, but a strep infection can lead to glomerulonephritis. So you need to treat the infection. But if you have chronic glomerulonephritis, what autoimmune disease did we talk about that causes chronic nephritis and leads to kidney failure? Lupus. Lupus causes chronic glomerulonephritis. It leads to kidney failure. It causes kidney disease. So it causes damage to the nephrons. So then the blood can't filter as well anymore. So signs and symptoms are going to be the same as for renal failure. If it's leading to renal failure, it's going to give you a sign of renal failure. Glomerulonephritis usually is an acute renal failure or a chronic renal failure. So signs and symptoms are going to be the same. They're going to have a lot of edema. They're and facial edema. Oh, I don't know why I wrote diagnosis up. What was I trying to say? I don't know. All right, kidney stones, or not kidney stones. Let me correct myself. Urolithiasis, because it's not only just in the kidneys. Eventually, the stones leave the kidneys and they go to the ureter and the bladder. So you could have bladder stones. You could have ureterolithiasis, or you could have nephrolithiasis. It's all the same. Lithiasis means stones. So remember, cholelithiasis means what? Gallstones. Yep, stones in the gallbladder. Lithiasis means stones. We don't really know why they occur. There are some things that put people at higher risk. But for the most part, the main thing you need to know about stones, one, the manifestations. The pain, especially if it's in the ureter, is severe, okay? Pain in this little ureter, traveling down here, is when people have the most severe symptoms. For a man, I was told it's like having a baby, pushing out a urinary stone. See, women, we could take more, you know, we just built like that. But no, for men, I was told by a nephrologist that for a man, it's like delivering a baby. Now, they're gonna have likely, depend on the location. If it's in the kidney, they may have just some dull flank pain. But if it's in the ureter, they're gonna be acting crazy, okay? They're gonna be crying. They're gonna be, might be flipping and flopping on the bed. It's very extremely painful. And depending on how large the stone is, they're gonna be maybe nauseated, vomiting, dry, heaving because they just feel so horrible. So the main thing with kidney stone is pain management. You have got to treat their pain. And when we go through study stuff after lunch, we'll talk about that. But pain, gotta treat the pain, gotta treat the nausea. And honestly, either you're gonna push fluids and they're gonna pee it out, or if it's too big, then they're gonna need to go for a procedure. Again, you're not becoming a urologist. You are a nurse. So you don't need to know the details of lithotripsy and how to perform it, because you're never going to do it. You're going to waste your time reading about how to perform a lithotripsy. What you do need to know is it is done using a cystoscopy. So what kind of things am I monitoring when they come back from that cystoscopy, or when they come back and they have a Foley catheter? What you're going to say? Come, sit it out. Rick, come on. Let's share.
No, I was gonna say cramping, but
You're gonna say what?
cramping.
Yeah, like, but still, same thing. So that's what I'm trying to show you. You don't need to know, I mean, you do need to know science. You need to understand what's going on in the body. But your main thing that you're being tested on is human, caring for these human beings with the disease. What things do I need to be watching out for, and how can I correct it if it happens? And when do I just need to pick up the phone and call for help?
So I was correct, it is the cramping, right?
Yeah, if they're in a lithotomy position, they may have cramping. What about their urine? It might be blood thin, but what if it's burgundy? What am I gonna do? Call somebody. Call somebody. You don't know what to do with that. Just call somebody. So, yeah, so that's it. That's what's going on with the stones. And what am I gonna do? I'm probably gonna be prepared to force fluids on them, get them to drink a lot of fluids or give them IV fluids, treat their pain. Remember, pain is a fifth vital sign. So in Maslow's hierarchy of needs, what needs come first? Physiological. So that's at the base, that which means top of the totem, that is important. Trying to get y'all prepared. I don't want nobody crying next week when you take the exam, because everything on the exam I done said verbally out loud. All right, BPH. Everybody heard of this? benign, prosthetic. In your book, it says hyperplasia. Somebody was like, we didn't know what that was. It said hypertrophy, and I didn't know. All right, hypertrophy and hyperplasia mean the same thing, okay? I was like, damn, you could have just figured I spelled the word wrong. Oh, I didn't know how to look it up because you put hypertrophy. You could have Googled that. It's 2021. So your book says hyperplasia, I say hypertrophy. They're the same word, okay? They mean the same thing. Enlarge is big. They got a big prostate. Ladies, can we get BPH? No. All right, I'm so glad y'all did that. Good. We're on a good start. All right. Ladies don't have a prostate. So this is obviously only going to affect males. Males over 50 years old. Any man can get it. Lots of men get it. They say, I guess, smoking and alcohol. I think they just don't want people to smoke and drink. I don't say other than your prostate big, but okay. Smoking and alcohol is what ATI told me. Sedentary lifestyle, Western diet, diabetes, heart disease. You don't, so age over 50. Don't need no knowledge, because I never heard of it. Age over 50. Signs and symptoms. Again, what is my patient going to look like? Men with an enlarged prostate. So here's the bladder and here's the urethra. The prostate wraps around the urethra. So once it becomes enlarged, it's cutting off flow. So what am I going to be on risk for? At risk for?
UTI.
UTI, yep, because I got urinary stasis, urinary retention. What's that going to feel like?
Painful.
Yeah, they're gonna feel urgency. They're gonna feel constant pressure, like my bladder's always full. What happens to these men too is positioning plays a part. When they stand up to go pee, they feel like they just can't do it. They'll say, I wake up or I go to the bathroom and I just stand there. I gotta go, but it won't come out. Or I have to push to get it to come out. Or I'm going, but with all this, my stream might be weak or it may just come dribbling out. But then what happens is at night they go to bed and they lay flat. When they lay down, it kind of relieves that pressure and it makes them have to pee a lot. That is what nocturia is. I have to keep, nocturia doesn't mean I'm wetting my bed. It means I'm waking up every hour, every 2 hours to go pee again. Why? Because finally when I'm laying down, that pressure is a little bit off my urethra, and now it's flowing. Things are flowing until I get in there and stand up. It is a struggle. Okay, the struggle is real with BPH. All right. So, and then they may have, because of irritation and stuff, hematuria, bleeding, all that. But the main thing is the urinary retention. And the stream is not consistent, and then it increases the risk for UTI. The 2 exams, a PSA is a blood test. Y'all got a question? No, we're talking about Oh, you're sounds like if you have enough cardiac, you probably could, but it work better if you just lay flat, but then you can pour and pee on yourself. Might not work. It depends on how big it is, but you're saying all right, PSA is a blood test. Usually, it used to be a routine screening. It's not so much anymore. Pretty much when a man, if they have complaints, they may check it or whatever. A PSA greater than 10 is going to be a sign of possible what? Prostate cancer. Prostate cancer. We're going to talk, when we do cancer, I would rather just go through all the cancers then I'd rather just, you got to know what's going on with each body system. The cancer part would be easy because cancer is cancer. You just need to know the signs and symptoms of which body part in the test. But a PSA may be elevated in BPH and it may not be. But a PSA greater than 10 is a probable prostate cancer. The other exam, the digital rectal exam. finger in the rectum. That is how they perform a prostate exam. Yeah, you go to MP school, but have your practice on the man. Hopefully. Yeah, so you can actually palpate if it's super enlarged. If you're me, and most people, you can go based off their symptoms. If a man is telling you he's 55 years old, he's having trouble using the bathroom, I'm not sitting up here, but I'm going straight to Flomax. I need some Flomax. I believe you. I believe I'm taking word for it. So there's two. Tamsulosin, there's two meds that are primarily used. You need to know BPH, you need to know TERP, you need to know these meds. Tamsulosin is an alpha-1 blocker. It relaxes the muscles a little bit, decreases bladder spasms, and helps relax the muscles of the urethra to hopefully get that urine to flow up. You may even see this periodically prescribed for a woman with what? Oh no, because it's gonna make you pee more. Why might I want you to pee more? Kidney stones. Women might get flow. It's the other name for this is Flomax. One of the common treatments for kidney stones is tamsulosin to help just get them to pee more and pee it out. But it's just a short stint. Versus if you have BPH, you take tamsulosin every day. The alpha blocker is going to relax the muscles, help you to pee more. Finasteride is hopefully going to prevent the prostate from enlarging more, because what it does is it decreases what the prostate is doing is producing testosterone. It decreases the testosterone production. So if finasteride is going to decrease my testosterone as a man, what is that going to do? It's not going to. Then I have erectile dysfunction. It's gonna be a sad day. All right. What else might I have? Erectile dysfunction. The other one is impotence. Impotence is the inability to ejaculate, right? And gynecomastia. So finasteride decreases testosterone. So the side effects of the finasteride are gonna go with a man who's not making enough testosterone. Tamsulosin is more just gonna make you pee more, and it is an alpha-1 blocker. So you know your beta blockers and alpha-1 blockers. So it could have side effects associated with your heart. Versus finasteride, you gotta be a girly man. No, I'm just kidding. All right, next, the TERP. TURP, transurethral, means they're going in with the cystoscopy, right? They're going in through the urethra. Transurethral resection of the prostate. So basically what they're doing, this is the prostate, they've gone in and they go in with the guide wire and they have this little shaver that's just shaving back the prostate, creating a bigger canal for the urethra to go through. So obviously, if I just stuck a catheter in you and did all this shaving and stuff, what's my urine going to do with blood, right? So because of that, when they come out of the TERP, they come out with what's called continuous bladder irrigation, CBI. They have a special Foley catheter. That catheter has an extra port, and it gets hooked up to basically IV fluids. So, and they are 3 times the size of a normal IV fluid bag. They're huge. They're continuously irrigating your bladder because of all the bleeding in there. What does blood do? It clots. Blood clots. So if blood is just sitting in my bladder, it's going to clot, and then I'm not going to be able to pee, right? If blood is sitting in my bladder and I can't pee, or if my bladder is a balloon, it's going to fill, and eventually it's going to burst. If your bladder bursts, you're going to die, okay? People can have their bladder surgically removed, but if my bladder just bursts out of nowhere, I'm probably going to die, okay? CBI must be monitored closely. A horrible story I could tell you from my career is working in med surg. My coworker, who later became a manager, A coworker's dad had a TERT. He was a patient on our floor. His nurse did not monitor his CBI and his bladder ruptured and he died at the hospital we work at. So could you imagine you killed your coworker's dad because you were not doing your job as a nurse, monitoring the CBI?
That is
When
so
you're
bad.
infusing all this into somebody's body, you need to be constantly checking, is it coming back out? The bladder is like this big. The fluids are that big, okay? If your bladder ruptures, you're going to die, okay?
Same thing happened when I was med surg.
Yeah.
Same thing.
Med surge, you would think, okay, TERPs, do them all the time, diabetes here for benign. Can you imagine going to work and knowing the person that's responsible for that? That's why I say, like, you can't just go on Quizlet and think you're about to become a nurse. You cannot. You're gonna learn the hard way. It's not gonna happen like that. Can you imagine the level of stress being that person that didn't check the CBI? Because I'm not saying that person probably wasn't a horrible person that came to work ready to kill.
What happened to her?
I don't remember what happened to her, honestly. I was like,
How often do you have to?
If it's wide open, it's like every 10
it shouldn't be wide open, but maybe when they first come out. But yeah, every few minutes, you and your CNA need to have a partnership of constantly going in, check, at least walk by the room, look at the back. Okay, urine still coming out. All right. No, yep, still good. All right, good. It's not burgundy. It's not full of clots or anything like that.
After that happened, we had the floor put up like every 15 minutes. We had to go in and mark it down anytime.
Dude, that was like the word. I was
It
like,
was terrible. It was
her
so
dad
I can't
died.
imagine being like someone.
You had to do
who-
what? You
Oh,
said?
She said the same thing happened at her hospital, and they had to go every 15 minutes and check CPI
yeah,
back.
It's like it's protocol now. So
It really should be, because you shouldn't die from that.
Please check it and then initial.
Yeah, you have to, because, or, look, you have to be smart. These things come with experience. We're teaching you by the book, right? As you get more, you say you've been a CNA like 20 years or something, so
Yeah, it's a big thing.
as you get more comfortable, it's only with experience, knowledge, and skills that you can cut corners. Me, if I know I'm about to go to lunch, I'm probably just slow the flow rate down, you know, but as a new nurse, no, do things by the book. People are like, look, we don't do that in my job. Well, I don't care. Come work at your job, okay? I know what the safest, best, most appropriate way to do stuff is. Cutting corners comes with experience. So just because you're at work and you see someone cut corners, doesn't mean they're a horrible nurse. They got that experience. If I've been a nurse 25 years and I've administered this same drug 25 years, I'm gonna feel much more confident giving it than if I just graduated 6 months ago. What were you gonna say?
Is there a specific indication for that? Because all the TURPTs that I've got, we've never sent them,
The nurse sets it up on the floor.
but I mean, so when it's all outpatient.
They go home. So that's probably a newer procedure.
Right.
Remember, you're going to
That's what
school
I
to be
wondered.
an RN. Huh?
That's why I wonder if there's a separate indication for them going to the floor.
Well, I don't know, because the training for an RN is primarily to prepare you to work in acute care.
Yeah.
So
Well,
you're not gonna see outpatient surgical patients
like,
on the
maybe
floor until something goes wrong.
Flushing for an hour, like the nurse.
Right, so that's probably a newer practice to
Yeah.
keep patients, look, it's 2021, cost of healthcare is high. Everybody now is just getting pushed back home. We don't care if you got a new hip, walk home, you'll be good. You need to put it to use anyway, practice. That's how the healthcare is now.
I'm just wondering if there's a specific.
I couldn't tell you, I'm not a urologist. It's probably a newer practice to keep patients out of the hospital. Let's just try to get you out of here. But in the hospital, you're gonna be doing this. Like, so,
Yeah.
but I know, like, when I worked on the floor, they didn't always have CBI. I would know, all right, I got a surgical patient coming later today. They're getting a TERP, like, oh, you have an admission later this afternoon. They're getting a TERP. Okay, I already know, I need to get boxes of fluids to my room, I need to have everything set up, because they may not set it up in surgery. It may be my job when I get up, they have the catheter, they have the Foley when they leave, but they don't have the CPI. Do your patients leave with a catheter?
They leave with the whole.
Okay, so I don't know what they do, maybe they have instructions though to constantly irrigate at home.
Maybe, and they.
So they're manually irrigating. Either way, you need irrigation.
I mean,
They are not going home and
They
not
won't
irrigating.
even, they won't even let them leave the OR until.
It's clear.
Yes.
And urine has to be clear. That's the indication that CPI is no longer needed when they're finally putting out clear urine. So probably in the hospital situation, you go to PACU, you wake back up, you go straight upstairs. They're not irrigating nothing in the PACU. They're sending you straight upstairs. Whereas outpatient, you're spending an hour irrigating them. They're not on CPI for days on end. They shouldn't be. They're usually on it maybe a day, maybe two. So you're doing the same thing, you're just not doing it continuously. I guarantee your patient's discharge instructions are to irrigate their Foley catheter at home.
But I mean, on the same side of that with the bladder rupture, I have seen patients start to crash
Yes,
using an old school cystoscope that doesn't have continuous outflow, that you have to constantly control the outflow, and the bladder gets too full.
and then it's putting pressure on the aorta and the venous, the vascular system. Yep, so yeah,
That I have.
yeah.
On the floor, I work real like you.
Yeah.
And I would have 4 patients with wide open.
I swear, and the CNA's like, oh, I got 2 CPIs, I hate this job. What a You're gonna see this constantly, all the time. You like it? Shoot, I don't know, I work with some roughneck CNAs, shoot, they don't wanna do that.
But a lot of the nurses won't put the CPI bag towards the door. It's like, hello.
Yeah,
You guys see if it's full or not.
exactly, and that's like a good trick, having it in sight, so I don't gotta keep going to your room, but at least if I can see the outflow. So, signs and symptoms for then again is gonna be that bleeding. You're looking out for bleeding, you're looking out for clots. If a patient has a catheter and they have clots, again, either if there's no option to irrigate, because you can irrigate a Foley catheter with an order. If there's no option to irrigate, then you have to call the doctor. Blood clots, because once that clot cuts off the flow of urine, they can die. Monitor, I know I already said that. And then the other thing, interesting thing I learned in ATI, you can teach a man Kegels. After the turf, yeah, I didn't know that. I didn't know. I was like, whoa, why would I know? But I'm just saying. I learned it in ATI. But basically, it's just teaching a man, because after this procedure, you know, the walls are a little loose, all right? They may have a little incontinence. They may not be able to control their urine as good because we've just gone in and we created this new canal, right? So you're gonna teach men afterwards Kegel exercises, going and stopping their stream, going and stopping their stream. Apparently they can do that. I don't know, I'm not a man. But that's what you're gonna teach them, Kegel exercises. So again, a weird fact that may come up on an exam. Right? Didn't it come up with you? You heard that before. Right? Mm-hmm. All right. Avoid heavy lifting after this procedure, and then increase oral fluids. They need to flush out that bladder. We're almost done. Then we're going to lunch. Polycystic kidneys. Yeah, you can't see. Polycystic kidneys, real quick, is just a genetic disorder. There's no risk factors except for your parents carry that gene. So polycystic kidneys, you just need to know it's just a genetic disorder that causes cysts to form in the kidneys. The picture on the right, this is what a normal kidney looks like. This is end-stage polycystic kidney, right? So it becomes full of these big, nasty, fluid-filled cysts. So if you know what it looks like, then these things will make sense. Obviously, that looks painful. I don't even know what it is, but it looks like it hurts, whatever that is. Hypertension is anything that's gonna cause kidney failure is gonna gonna cause high blood pressure, and then high blood pressure is gonna cause kidney failure. So kidney failure, high blood pressure, constipation. These big old kidneys, it's in the retroperitoneum, so now you're taking up space, obstructing my bowels. So they're gonna have constipation, their urine coming out of that is gonna look probably bloody and cloudy. They're gonna be at higher risk for stones, higher risk for infection, your UTI. So you have to monitor them for signs and symptoms of infection. And then hyponatremia, their kidneys aren't working, they're retaining fluids, yada yada. So then, only thing you need to know is polycystic kidneys. One, looking out for infection, but two, it's going to eventually lead to kidney failure. They're going to end up on dialysis as they get older and older. Acute renal failure. So there's 3 types. Now that we talked about all these disorders, pre-renal. Pre-renal is whatever's causing my kidney failure happened before it got to the kidneys. So either I'm not drinking enough fluid, I don't have enough fluid in my body, or I don't have enough blood flow to my kidneys. So it could be anything that causes decreased blood flow to the kidneys. Heart disease. If I have a renal artery stenosis, which is hardening, when we talk about circulation, hardening and thickening of the blood vessel walls, you know, when you try to draw blood from somebody and their veins all hard, they've been smoking cigarettes their whole life, that renal stenosis. So if you have renal stenosis, you don't have good blood flow to your kidneys, that's pre-renal. If you're in shock, if I just got shot 12 times walking down Okeechobee and I lose 3 pints of blood and I'm in shock, there's not thug life, all right? I'm not get enough blood flowing to my kidneys. So look, my body is gonna hold on to the blood in the places that truly matter. My heart and my brain. All right, everything and my lungs. Heart, brain, and lungs. When people say, oh, you're in shock and they clamp down means my body knows I ain't got enough blood to be taking care of everybody, okay? Heart, lungs, and brain is gonna keep me alive. The rest of you organs and body parts, you just don't have to suffer, okay? When I get some more blood, I send it your way. But when I'm clamping down in shock, I'm only worried about my heart, lungs, and my brain. So shock, anything like that, that's for intrarenal, glomerulonephritis, pyelonephritis, diabetes, hypertension, anything that's causing a direct injury to the kidney is intrarenal or intrinsic, is inside the kidney. Postrenal, that means the issue is after the kidney. So if I have BPH and I have constant obstruction, if I have a kidney stone that now went down to my ureter and that's causing obstruction, now urine's backing up, that's post-renal. So everybody gets pre, intra, and post, right? All right. It's only like a few more slides. We'll be out of here by 12:10 and get an hour for lunch. Stages, the stages. I mean, I got this straight out of ATI. You can read your book. First it begins. The disease commences. Okay, whatever's going on, you're gonna have signs and symptoms. As you progress to acute renal failure, your urine output is gonna be decreased. Oliguria. Oliguria means you're only voiding small amounts of urine, infrequent amounts of urine. Okay, you may only go pee twice in one day. Anuria means no urine output at all. People who have end-stage renal disease, over time, they lose the ability to even make pee, and they don't go to the bathroom at all. As your kidneys get better, you're going to start to diurese, urine's going to be made again, and then you're going to recover. That's great. All right. So acute renal failure and chronic renal failure, it's going to be pretty much closely the same, except for acute means it's reversible, right? But you could have acute on chronic. Like I could have chronic kidney disease stage 2 and then get super dehydrated and see that GFR go down suddenly, but then get rehydrated and go back to just kidney disease stage 2. So you can't always have acute on chronic. I can live every day with chronic COPD and then have an acute exacerbation that lands me in the ICU and then get better and go back to live my regular smoker life of COPD. So when they have acute renal failure, the main thing is trying to figure out what caused it. We need to figure it out. Was it a nephrotoxic drug? Maybe they're on a certain medicine. What kind of failure is that? Pre, intra, or post? It's going to be intra. Intra. If a drug is nephrotoxic, it's hurting the kidney directly. Okay? So, if I'm taking like, I don't know, what's a nephrotoxic agent? Gentamicin. Gentamicin is an antibiotic that directly causes injury to the kidney. So then what am I gonna do? Stop the gentamicin, give them some fluids, let them flush it out, and their kidney function should get better. Monitor vitals and all that. CVP, you don't need to worry about so much. We'll talk about that with circulatory system. But monitoring central venous pressures is good for determining if a person's in shock, or if they're dehydrated. Not if they're dehydrated or shocked, but if they're need fluids or if they are just vasodilated. Monitor eyes and nose, labs, all the rest. Common sense. Now, if they're in acute renal failure, you may give them diuretics. You might give it to them to help them get rid of potassium and electrolytes and excess fluid. You might give it to them to kind of give their kidney a push, a jump start. But if I have chronic renal failure and my kidneys don't work at all, are diuretics going to work?
No.
My kidneys have to work for the med to work, right? So you're not going to give it to somebody who's like completely renal failure. But if you're just 25 and you took, I don't know, gentamicin and now you're in kidney failure, they may give you diuretics. And then the rest of these drugs, sodium polystyrene sulfonate, also known as K-Exolate. Everybody know what K-Exolate does?
Excellent. The K, vitamin K. Exit.
Cause that K to exit. Yes. It's like lactulose. That was good. K-Exolate. Sodium polystyrene is similar to lactulose. Like lactulose is a nasty liquidy laxative that you give to get rid of what? Ammonia. That was lactulose. But K-Exolate, sodium polystyrene, you're getting rid of potassium. It binds to the potassium, sends it to the valve, poop it right on that. You're gonna treat, if someone has hyperkalemia or or renal failure, they're gonna be at risk for metabolic acidosis. Metabolic acidosis also causes hyperkalemia. People with renal failure, remember, calcium is low, phosphorus is high. They end up with this pseudo hyperparathyroidism. It's on the study guide. Hyperparathyroidism. All you need to know about that is it's going to cause excessive phosphorus and low calcium. So people on dialysis, if you work in a hospital, when you go to clinicals again, I want you guys to look at their meds for dialysis patients. They all take a phosphorus binder with every meal. It may be Selvamir, it may be calcium, it may be Tums, calcium carbonate. If you give them more calcium, the phosphorus will go down. So calcium acetate, but you'll see, they'll tell you even, I need my binder. I can't eat my lunch tray. The nurse didn't give them a binder. They're gonna tell you. Watch their meds, because every dialysis patient takes it to get rid of the phosphorus from their food.
You said metabolic acidosis, right?
For kidney failure, yep, metabolic acidosis.
You said
Hyperkalemia.
hyperparathyroidism.
It's hypo. Isn't it hypo?
What did you just say with the calcium and phosphorus?
Hyperparathyroidism and hyperphosphatemia and hypocalcemia for dialysis patients for kidney failure. Now, just think about it, no matter what the disease, the whole goal as a nurse is to prevent kidney failure. So all these questions are gonna be aimed at you know, what steps do I need to do to prevent further injury to the patient? If they have a UTI, I don't want them to get septic or kidney failure. If they have BPH, I need to stop that obstruction. I don't want them to get kidney failure. If I have glomerulonephritis, or if I have renal failure, diet's gonna be the same. You're gonna be restricting fluids. You're gonna be restricting kidney failure is kidney failure. It doesn't matter what caused it. I mean, of course, you want to get down to what caused it, but if the kidneys are failing, it doesn't matter why, they're going to all be failing in the same way. They're going to fail. Same with liver disease. If the liver is failing, doesn't matter if you took 45 Tylenols or if you drank all your life, liver failure is liver failure. So risk factors, like I told you before, diabetes, #1 cause of kidney failure. Diabetes. And I'll show you in a second. Diabetes. So who's going to be at highest risk for end-stage renal disease with diabetes? African Americans. It is critical that you teach your African American patients about diabetic care and taking care of blood pressure so they don't get to this. Chronic glomerulonephritis, everything we just talked about could lead to chronic kidney disease. Complications is death. Without dialysis, you will die if you have end-stage renal disease. So remember, it's levels to this stuff. Stages 1 through 4 do not require dialysis. When you get to stage 5, that is end-stage renal disease. Because you'll be out here at work like, wait, but it says the patient has chronic renal failure. Why are we giving them those bananas? Well, they're not at end-stage renal disease yet, so they may or may not be on a renal diet. The only thing I want to show you is, again, the reason diabetics end up in that state is because glucose is much too large to pass through those glomerulus, that basement membrane like the lady showed you. Glucose molecules are too big. They're too big and they're going to destroy small capillaries, small blood vessels. Like blood comes from your heart in an artery, then it gets a little bit smaller, and then there's capillaries, little tiny capillaries all over your organs. Glucose, it can travel through the artery and everything just fine, but when it gets down to the arterioles and the capillaries, it can't. It's just going to destroy them. You end up with nerve damage and tissue and organ damage. Same with protein. Again, this is a glomerulus, so imagine these big blue balls, like Joe G said yesterday, these big blue balls are going to be trying to travel through the glomerulus. The normal particles, electrolytes and things like that are little tiny yellow balls. But if I have protein or glucose, they can't travel through here. And they're just destroying my nephrons. But remember, you have millions of nephrons. So you don't just wake up in end-stage renal disease unless you took some sort of poison or something crazy happened, or you got shot, lost your kidney or something crazy. You don't just wake up in end-stage renal disease. You have millions of nephrons. So this filtration takes time to keep beating up all your nephrons until you have kidney failure. Hence why people are walking. I've got no problem. Yeah, my blood sugar 472. I don't care what we eat for lunch. I don't care because I'm not going to feel those symptoms necessarily right away. Your body always adapts to stress. Some people, if you work in a hospital, you know patients whose blood pressure every day, 200 over 100, 200 over 100. You have patients, they become so used to it that you can never get their blood pressure to 120 over 80 because they'd likely go into shock because their body has adjusted to 200 over 100. So your goal for them might be like, I just want Mr. Johnson to have a 160 over 95. If he has 160 over 95, I'm all right with that. That's perfect for him. These are just the signs and symptoms. You could read that. I mean, it's in your book. Edema, they're going to hold on to water, and potassium is always hyperkalemia, metabolic acidosis goes with chronic renal failure. I think that's it. Oh, there might be just the dialysis stuff. I could talk about dialysis when we come back from lunch. Let's take a break. No, you don't want to take a break? So, like we said, when you get to that stage of end-stage renal disease, then the only option is dialysis. But before, we'll talk about dialysis in a second. Before we get there, stages 1 through 4, or a patient who's in acute renal failure, here's things we can do to prevent further damage. And then once they're in renal failure, renal diet. Remember, you're gonna have high phosphorus, you're gonna retain water, so you're gonna need to keep a low sodium and low fluid intake, high carbs for energy, but the potassium's gonna be high, so the diet needs to be low in potassium. And then remember what I showed you about the protein molecules being filtered through the glomerulus. Because now they're in a state of failure, you need to keep them on a low protein diet. So renal diet is probably the most restrictive diet, because of all the things they can't have. Medications, we talked about the phosphorus binders, calcium carbonate, what is that? That's Tums. All these different meds, these are those pills I told you that dialysis patients will take to bind to the phosphorus in their diet. So these meds here you will need to know for your exam. Epoetin, or however you say it, I call it Epogen because that's the trade name. Epogen is like a man-made synthetic erythropoietin. Erythropoietin does what? Helps with what? Make red blood cells. So giving a dialysis patient Epogen is going to help them with anemia. I've seen Epogen used for patients who are Jehovah's Witness and are severely anemic. Because what's one thing about Jehovah's Witness?
They don't take blood
They do
products.
not accept blood products. Well, does that mean, oh, you're Jehovah's Witness, you have anemia, we'll just let you die? No, we gotta come up with other ways. So Epogen, I'm emailing you this right this second. I got the email pulled up. So Epogen is gonna help, it's a synthetic erythropoietin. So it's gonna replace what they're not getting. Epogen, if I'm making a lot of red blood cells, this is just a side note, but Epogen will come up again. The thing about Epogen, when you have a patient on it, that's not something it's not like LASIK, so I'm just gonna write your prescription, here you go, you're gonna be on this. It's an injection, A. But B, that requires a conversation with the doctor, because any medication that's gonna increase the production of red blood cells, you're gonna be at risk for blood clots. And what is a blood clot likely, what can it cause? Stroke and heart attack, well, pulmonary embolism and heart attacks. So anybody that is taking Epogen, they need to be made aware that there is an increased risk for stroke or heart attack. So that's when you talk about risk versus benefit. How really bad is their anemia? You know, is it bad enough that if I don't correct it, that they'll die? Then I probably would recommend Epogen. But I mean, if your hemoglobin is regularly at 8 and you're not dying of anemia, I might just give you some iron. Okay, so you have to think about risk versus benefit. So Epoetin, how did I say it? Epoetin alpha, Epogen is to help make red blood cells. Same with iron. Ferrous sulfate, that's just an iron supplement. If a person has anemia, although iron aids in the production of red blood cells, right? So of course, if I have low iron, I'm gonna have iron deficiency anemia, right? We know that. Don't worry, that's not on your test. You'll get that next test whenever we talk about hematology stuff. But if I already have anemia and my body needs to make more red blood cells, eventually it's going to waste up all my iron stores. So the dialysis patients don't have iron deficiency anemia. They have anemia, which has now caused iron deficiency. Everybody get that?
So they take epoetin for iron deficiency.
No, they take epoetin to make red blood cells because their kidneys does not make erythropoietin anymore.
Mm-hmm.
And then they take iron because of that anemia, their body has wasted up a lot of iron trying to keep up with the lack of erythropoietin. And then sodium polystyrene, we already talked about that, that's KXLA. That's the one that's gonna make you excrete potassium in your stool. So now we talk about dialysis. No matter what type of dialysis they're getting, obviously I need to monitor their labs closely. I need to watch their electrolytes. I need to make sure, you know, they're not having fluid overload or dehydration. Happens all the time. People go to dialysis, they take off too much fluid. Now the person's in hypovolemic shock or cardiac arrest. You need to monitor the site, whether it's in the peritoneal cavity, whether it's in my arm, whether it's in my groin, wherever that dialysis access site, whether it's a catheter, whether it's a fistula, and I'm gonna show you pictures, don't worry. Wherever they are getting access for dialysis, my job as a nurse is to monitor that site. And we're gonna talk about that in a second. You're going to weigh the patient before and after.
Why?
9 times out of 10, the dialysis nurse is gonna weigh them after.
Why?
Why? You're removing fluid. The
Okay.
best indicator of fluid status is body weight. Heart failure, daily weights. Renal failure, daily weights. Weight is one of the best indicators of my body fluid status. If I'm gaining more than 1 to 2 pounds in a day, that's 2.2 to 4.4 kilograms. That's a lot of damn water. So body weight, you have to, usually in my patients go on dialysis, I'm gonna weigh them. And likely they'll go to dialysis or the nurse will come to the room, do their dialysis, and they're gonna weigh them afterwards. Every dialysis patient knows their dry weight. Dry weight. Ask any dialysis patient, what's your dry weight? Oh, I'm 47 kilograms. They know that because that's the goal. When they're going to dialysis, we're removing enough fluid. You should be about back to your dry weight. If we remove too much, we probably pulled out too much fluid. Or if you still are so many kilograms over your dry weight, now you could have just got back because of, you know, Christmas break. But for the most part, with dialysis, heart failure, anything that's going to cause a fluid volume discrepancy is daily weights. Nephrotoxic agents, you're going to need to know these for your exam. What type of drugs and substances are going to cause harm to the kidneys? What's the one? Give me an aminoglycoside antibiotic that causes kidney nephrotoxic. Gentamicin, and what's the other one? Vancomycin. Those are big ones. Nephrotoxic, gentamicin, vancomycin. NSAIDs. So with the liver failure, right, we don't want to give them Tylenol because Tylenol has to be filtered through the liver. NSAIDs are filtered through the kidneys. So if your patient has a fever or whatever, you're not going to give them ibuprofen, but you might give them Tylenol because their liver's still working. Their kidneys aren't working. ACE inhibitors and ARBs can cause damage to the kidneys. IV contrast, we already talked about that. And if you take metformin with it, it's going to be even worse. And then always, these people have kidney failure. I got to be mindful of the electrolytes I'm giving them. I want to be mindful about giving a dialysis patient potassium or magnesium because their kidneys don't work. That stuff's not going to go anywhere. Majority of all the potassium in your body is filtered out through the kidneys, and all the magnesium is only filtered out through the kidneys. So you have to be extremely mindful. You pretty much avoid administering magnesium to anyone on dialysis or anyone with kidney failure, because it has nowhere to go, because they're going to have hypermagnesemia. If I have hypermagnesemia, what other electrolyte's going to be high? What else? Which one is going to probably kill me? If mag is high, potassium. Potassium is high. They go hand in hand. And then I'm going to have dysrhythmias, metabolic acidosis. So dialysis, what does it do? It takes on the job that the kidneys couldn't do, the filtering job. The dialysis is going to make erythropoietin, and it's not going to convert vitamin D to calcium. It's not going to do all that. It's not that advanced. But it is going to remove the waste, filter your blood, and it will remove hydrogen ions to help correct acidosis. If somebody's in a serious acute renal failure, though, you don't have to be end-stage renal disease. If you've ingested some type of poison, or if you try to kill yourself, overdose on whatever, or if you have something else going on that caused like the patient I was saying, if a patient had a crushing injury and all these cells are damaged at the same time, and now their potassium is 7.6, they are going to die. You don't got time to be waiting for them to poop. All right, did you poop yet? Did the potassium come out? No. You're gonna get a catheter, you go into dialysis, okay? I think they're even using dialysis. Are they using that for COVID? No, that's me, I'm not a COVID expert, but I mean, dialysis, it doesn't just have to be you have end-stage renal disease. It can be used to clean the blood when the blood needs to rapidly be filtered. They do use it, right? Yeah. So the thing about end-stage renal disease and when a patient gets to that point of needing dialysis, it's not just a physically taxing thing. It is emotionally and mentally painful for them. Their whole life changes. First of all, you tell me I got an end-stage vaginitis, I'm gonna be depressed, okay? Anything end-stage, what does that mean to me? That means I'm probably dying, right? When you tell me I have something end-stage, so I'm gonna be stressed, I'm gonna be depressed. A lot of the dialysis patients are very angry, and rightfully so. I will be mad at the world, maybe mad at God, whatever, if I had to go through this. So you always gotta try to put yourself in the next person's shoes. Just because, oh, well, they're just angry. Oh, he's just an a-hole. I mean, that could be so, but likely you gotta dig deeper than that. Why? How would I feel if I gotta go to DeVita over here in the strip mall 3 days a week for at least 5 hours a day? And then by the time I get out of there, I'm so tired and physically drained, I don't have a life. The next day, I'm so tired from dialysis yesterday, I'm probably just gonna sleep so I can get up at 4 a.m. to go to dialysis again tomorrow. It's a very depressing life, okay? So that's why we don't want people to get there. You can live 20 years on dialysis, but who wants to do that? You know, that's horrible. And then the only other option would be what? What's the only other thing I could get besides dialysis?
Transplant.
A new kidney. So, what would be signs if I got a new kidney and was failing?
Organ rejection?
Yeah, I mean, failing would be signs that they were being rejected. You know what I mean? So if they're creatinine and BUN, if they start looking back like they're in renal failure, obviously their body has rejected the organ. That's it, that's all. If the organ I put in the body is back failing again, because if I'm a dialysis patient, I get a new kidney, I shouldn't require dialysis anymore. That's gonna be a life changer for me. So I'm gonna take my anti-rejection meds because now I got my life back. So anti-rejection meds are gonna put me at risk for what?
At risk?
At risk. Anti-rejection meds are gonna put me at risk for what? Infection. They are immune suppressant. That's all you need to know about kidney transplant. You don't need to read the whole chapter on kidney transplant because you already learned transplant. No matter what's being transplanted, all I need to worry about is that organ not going back into failure and administering immunosuppressant drugs and making sure that they don't have infection. That's all you need to know, any transplant, okay? And then the other thing, contraindications for a transplant. What may keep me from getting a transplant? Being an alcoholic or a drug addict. Abusing, what am I giving you a new kidney for? Just so you can blow it out again? It is hundreds of thousands of people waiting for these organs. Children, young people, people who were just born with polycystic or kidneys or something. There are too many people waiting for these precious organs to be giving old Uncle Joe the alcoholic a new liver every 6 years. You're not gonna get it. You have to be able to prove that you are sober, like you've been sober for more than a year, I think it is. You have to have documented proof. So being an alcoholic, a drug addict, or even being just generally unhealthy to some degree, if anything else that would keep you from getting any surgery, if your body couldn't withstand surgery. But alcoholism, drug addiction is a contraindication for any transplant. Well, liver, organ, organ transplant. So anyway, dialysis, if it's temporary or if it's new, they're gonna have a catheter of some sort. Might be in the chest, might be in the groin, wherever. Depends on, how good their their veins are. But usually it's up in the chest. So for me as a nurse, I don't even know what vessel this thing goes into. I don't even know none of that. I need to know, I need to monitor this site, make sure what will be a sign it was infected. Heat, redness, warm, heat, pain, and purulent drainage, swelling, whatever. That's it. That's my job as a nurse. Make sure it's not infected. Make sure they don't have a fever. Make sure there's, a nice, clean, sterile dressing around it. It shouldn't be hanging out like this. I don't know if anybody's ever seen that. It should be.
We just watched it this weekend.
You got to watch them change it?
No, we watched dialysis.
Oh, you did?
Yeah.
Okay. And so when the nurse was done, did he have this? Did the patient have this or a fistula?
No, we had that.
This one?
No.
Okay. So he probably did the dressing change when they always, the dialysis nurse. It's a sterile dressing because it's going to a central line, sterile. So you're just monitoring that. We don't use these this is not an IV. We don't insert medication in there. Don't let me say never, because if a patient's critical and we don't have an access, we will use it. But 99.9% of the time, my job as a floor nurse is to monitor the site. If they have an AV fistula, what happens is, if they're gonna be on long-term dialysis, they're gonna end up with this, if they're getting hemodialysis. If they get a fistula, it takes 3 to 6 months for the fistula to mature to be usable for dialysis. So, say you had kidney failure for the last 10 years, you're getting worse and worse every year, you're about stage 4, your kidney doctor already knows we're gonna get to dialysis one day. So I'm gonna make you an appointment with a vascular surgeon so we can get a fistula going now, so that in 6 months, when you finally do need dialysis, it's working. What's my job as a nurse to monitor the fistula? Who said that? Bruit and thrill. Yes. So what's a bruit? Does anybody know?
When there's too much blood flow, like
It's turbulent blood flow. So it's a swooshing sound. So when I put my stethoscope to this, it will sound almost like a baby's heart tone on a fetal heart monitor. That's how it sounds. The noise of turbulent blood flow. This is the only bruit that's a good bruit. Okay? So when someone has an AV fistula, I want to listen for a bruit. That's something I can hear. But say, if I'm listening to your renal arteries, which you're never going to hear anything unless they have something real bad going on. But if I was listening there, or if I was listening to the carotid artery, and I heard a bruit, what could that be a sign of?
Carotid artery, say it again?
Yeah, if I'm listening to a blood vessel and I hear a bruit, it's gonna mean that there's turbulent blood flow through that artery, right? Why is it turbulent? Usually because plaque has built up on my arteries and it's narrowed. The blood vessel is now narrow because plaque is built up. You don't need to know this week, but when we get to circulation, just knowing a bruit, that sound, it means turbulent blood flow. Bruit is the same sound you hear in a murmur. A murmur is it's the same thing. It's turbulent blood flow through a damaged heart vessel. So that sound, that is not, on an ultrasound, that's okay. But when I'm listening with my stethoscope and I hear that, that's not a good sound, except for when I'm assessing an AV fistula. Because an AV fistula is just that. It's an artery and a vein with a new communication between them. A fistula, remember when I told you about stool coming out of the vagina?
Mm-hmm.
That's an anal
That's
vesicle.
not a good thing in all cases. Fistulas are not good in all
Fistula is
cases.
not good, except when I need dialysis. We created, this was a surgically created fistula. We made this for a reason, because the way dialysis works is, I'm pulling blood out of your body, out of the arterial, coming out of the heart, I'm getting this blood, I'm cleaning it out, and then I'm gonna put it back into your venous system so the blood can go back to the heart and go out to the rest of your body. So That's what dialysis is doing. It's doing the work of the kidneys. The blood is being filtered instead of going through the glomerulus.
So
and all.
they put both of them together. They stick both of the veins together. Is that
Yeah, so the fistula, AV fistula, arteriovenous fistula. It is an abnormal communication between the artery and the venous system. So for me as a nurse, I heard a brewery. What is a thrill? A thrill is it's a bounding pulsation. It's gonna feel like a vibration. You're gonna feel it. So when you guys go to clinical this week, next week, try to find a dialysis patient and ask them if you could assess. They don't care.
Is it like a jugular vein, like an extended jugular vein?
It looks like this. It looks like this. You guys have probably seen people in public. There's so many people on dialysis. You see people all the time. And when it gets worse, sometimes, or if they've had 5 of them, they got them all over the place. You see them, you just didn't know what the heck that was. What's wrong with that person?
I had a dialysis patient last week, but she had the 2 things in her neck.
Yeah, so she's probably been on dialysis a long time. So that's why I say usually the catheter's in the chest, but when you start seeing them down in the groin and weird places, that's because this person has been stuck so many times in so many places. That area then got scarred up. If I don't feel a thrill or if I don't hear a bruit, that means that thing's probably clotted off. It's either clotted off, there's not enough blood flow to that. Somebody needs to be notified of that. Because if my fistula isn't working, how am I going to get dialysis? It's not like an emergency, oh my God, call 911, but it needs to be addressed within the next 24 hours. Because if I have to be dialyzed every Monday, Wednesday, Friday. So if Tuesday my fistula isn't working, I need to hurry up and get to the hospital, get back to my surgeon, somebody, because they probably need to do something to open it up. It could be a narrow blood vessel, it could be a blood clot, but if they don't have a bruit or they don't have a thrill, if they don't have one or if they don't have both, the fistula, something's wrong with my fistula. Does everybody get that?
Yes.
So I said, when you go to clinical, check for a bruit and thrill, find somebody with a fistula and ask them. You'll be like, oh shoot, okay, you'll feel it. Somebody even told me, what were they doing? You can hear it sometimes or just see it, like you could be touching their arm and feel this strong vibration. It's strong. So just try to assess it. That's really your job. And then the daily weights, the vitals and the labs, you already know that. So again, you're not a freaking nephrologist. You're not a chemist, okay? You don't need to know the ins and outs of dialysis. I don't know nothing about dialysis, okay? I just call the doctor if we need dialysis orders or something and write them down. And I pass that information on to the dialysis nurse who's now been specially trained in dialysis. If you want to go work at DaVita, I promise you they're going to give you a class on how to handle dialysis. All you need to know is assess the site, prevent infection, and wait on and watch your labs. What's up?
Are you only hearing during dialysis, or is it
All the time, all day, every day, at grocery store, everywhere. That fistula should always have a bruit and thrill. You should be checking that before they start dialysis. Because if there's no bruit and thrill, they can't do dialysis. So now peritoneal. The only difference with peritoneal is, okay, one, people prefer peritoneal. A lot of people prefer it because they don't have to go to the dialysis center to do it. They do it at home. They have a catheter that's inserted into their peritoneal cavity. It's just free in there. And basically your belly serves as like a reservoir. So instead of sucking the blood out into this machine and cleansing it there, what you're doing is they're injecting this dye. Well, you just hang it to gravity, but they're putting this dialysate, this chemical. You don't need to know all that. But warm it first. Write that down. Warm it first. Put it in, and then it stays in for a little while. You don't need to know all that, but it stays in for a little while. You clamp it, let it sit there, and through osmosis, filtration, all that movement of fluid, it's going to be able to pull out those electrolytes, and then you drain it out afterwards. 9 times out of 10 patients do this themselves. So that's That is why, when I first started in nursing, nobody did peritoneal dialysis. It wasn't out, I don't think. I've never heard of it until probably I was a nurse several years. But 9 times out of 10, you're probably just gonna get the patients the supplies they need, because they do it all the time. And 9 times out of 10, if they do it at home, they don't want you to do it to them. Like, people will tell you, can I do my own insulin? I don't want you sticking me. That's fine. You can stand there, you can watch. If the patient been giving themselves shots 45 years, here you come fresh out of HCI. Let me do my own shot, okay? You know, so just give them the supplies and observe and make sure they're doing it safely. But for dialysis through the peritoneum, you need to monitor that catheter site for infection. Same thing, body weight, all that is the same. Monitoring electrolytes is the same. And then just knowing, giving them cold dialysate is going to cause cramp. I mean, if I inject ice cold water in my belly, what do you think it's gonna feel like? Probably not good. Put it, warm it up. I want a nice warm belly. Okay. What's the biggest concern with peritoneum? What's going to be the worst complication?
Probably just like
Besides the fluid imbalance. In fact, which peritonitis. So you're going to monitor them for signs of peritonitis because they have this cavity, this catheter in the peritoneal cavity. So a lot of people prefer this, but they do end up having a lot of problems with infection. Why? Because they're doing it at home. They don't got like a sterile field set up, you know, they're probably eating Doritos, setting it up, watching Judge Mathis. And they have to do it every day. They have to do it every day. Only hemodialysis is 3 days a week. This is like an all-day process. So to me, this doesn't sound any better, but for some people, they'd rather be sitting in their recliner chair at home than in somebody else's dialysis chair. So, and then last slide, you just need to know these meds, but we already went over. The rest of that, you don't need to know. All right. The rest is from, I don't know how, because this was the slideshow. This is not the most up to date, but the one I'm about to email you is. Does anybody have any questions about that? No? Okay, great. Awesome. All right, so the slideshow I just had up, I'm going to email to you guys. And now, before I pull up the wrong thing, I want to go over some stuff for the exam. So first and foremost, actually, let's run through, everybody got the fluid and electrolytes worksheet? All right, this is just, wait, is this one page or two? Wait a damn minute. Oh. Huh? You forgot yours at home? Yeah, I can bring them, hold on. Yeah, if you didn't turn it in. Yeah, I don't care. I just want to go through the answers. Here, you need one. I don't know how to do it. I ain't got time for this shit. It's only one. This is one page, and this is one page, okay? Take one of each. It might be somebody. Not good. All right. Okay, as far as the exam, I want to pull that up. This paper I just passed out. All right. All right. Just want to pull it up. They both, they're from the same book. And honestly, I'm gonna post this whole book on Moodle. You probably got it last semester. I could email it too. I'm putting together an email for you guys now. Let me go. All right. Okay. All right, so let me see, what page was that on? Does it say a page number on it by chance? Don't worry, I got it. One of them is two-sided, right? Okay, I was just making sure I gave you all the pages I wanted you to have. Okay. And I'm gonna upload this whole book, so don't worry. But let's talk about, I want y'all, close that. Hell is it? Okay. All right. Because I keep saying the same thing, but let me put it in your face on how to answer these questions on these exams. I cannot stress enough prioritization. Sometimes the questions, all four of them are right? All four of them go to that disease or whatever. You always have to consider safety first. Safety. Safety means ABCs, right? Safety, airway, breathing, circulation, and then if you look at the bottom of the page, disability. Airway obviously is, my airway obstructed. Listening to lung sounds, all that has to do with airway. Listening to lung sounds, assessing the airway, all of that has to do with lung sounds. Breathing, all that has to do with airway, sorry. Breathing, I'm checking your oxygenation. I'm checking your pulse ox. I'm checking your lung sounds again, respiration. But of course, airway, am I gonna check airway first or am I gonna administer oxygen first? Check airway first, airway first, airway. Breathing is the same thing, oxygenation and all that, but assessing the airway first always comes first. Circulation, that could be by checking what? Pulses, assessing heart tones, assessing capillary refill. Those are ways to assess circulation. Then you get to D, which will be disability. So that would be level of consciousness. That would be, injury, level of injury. Am I going to end up paralyzed or whatever? If you got a patient who's in respiratory distress and you have a patient who's whatever's going on with them, they're going to lose their legs. You gotta work with the respiratory distress first. They're in the most imminent danger. You'll be all right without your legs. I'll get to you in a second. But if this person can't breathe, they're gonna die quickly. Even the heart comes after the lungs. Airway first. Airway. So that's why there was a question about, I'm about to get to you, Kanisha. A question about the EGD. Patient went to the EGD and they were saying, assessing gag reflex or level of consciousness. Those were the two answers that people were stuck on. Level of consciousness is down here at level of disability. Gag reflex is my ability to protect my airway. So that comes way before level of consciousness. So does everybody understand that? What's up, Kanisha?
Bleeding out. Where does that go?
If a patient's bleeding out, again, it depends on the answers. It depends. Bleeding out is, another thing is, it's the potential for injury versus actual injury. So it depends on the question and what they're asking for. Bleeding out obviously is an emergency, but if it's between the patient bleeding out and the patient that is right now in respiratory distress, we got a little time, you can bleed a little bit, maybe a minute. I might only have 1 minute, but I know I gotta get to this respiratory distress right now, because they're gonna die right now. Somebody, I can send the CNA, hold pressure. Tell the patient, hold pressure. But airway, we gotta protect the airway first, or there's not gonna be anything else. So that's the thing, just safety, what answer is talking the most closest to the patient's safety? What answer is gonna cause the most imminent danger to this person's health, to their life? What is the most life-threatening answer? That's why I say 4 answers may be right. It's just prioritizing which answer is the right fit. So then on top of that, that goes back to this part, Maslow's hierarchy of needs. Physiological needs come first. Physiological, now safety, we're not talking about your physiological safety, we're talking about feeling secure and safe, okay, versus if I don't fix this person could die or their health outcomes are gonna be worse. So physiological needs, the 5 vital signs, pain. Pain is gonna come first before, feeling safe or preventing infection even. Actually, treating the infection is gonna come after treating their severe pain. Right there. Gonna have questions like that. That's gonna trick you, and you're gonna say, but you said airway was first. No. Pain is one of the top priorities on that. It's a physiological need. So pain is up there with airway. When actually, technically, if you were working ER and the triage, how you triage a patient, even though we know patients say whatever, but if a patient is having a stroke or critical care, they're gonna be level 1, right? If a patient's suicidal, they're also up there, level 1, level 2. And if a patient says their pain is 10 out of 10, they're supposed to be level 2 as well. So they're up there. Pain is something that is necessary to treat because the way the body reacts to stress. So I just want you guys to really, when you look at the questions, that's the thing. People say, oh, it says diabetes, A1C. All right, I'm gonna just circle A1C. You didn't read the whole question. You just saw A1C. You knew that a hemoglobin A1C with diabetes, so you just circled it. And now you got the answer
Do you
wrong.
have the answer for somebody who changes the question completely altogether?
Stop doing that. Don't do it. Don't do
All
it.
together?
Just prioritize your answers. Prioritize your answers. Don't change it. If you're stuck, it's always going to be 2. There's always 2 that get you stuck on the nursing exams. Just again, which one? All right, all right, airway, are we talking about ABCs? Okay, that doesn't apply to this question. Think about Maslow's. Think about, that's how you prioritize your answers. And honestly, 9 times out of 10, if you go with your first mind, you're gonna be better off. So read this sheet. I'm not about to sit here and read it to you, but that's why I gave it to you, was to help you just in test taking in general, NCLEX in general. The other thing was, the other sheet I gave, I'm gonna send you this whole book, but I just gave you the pages she had in here. It's just 1 page, quick snapshot looking at electrolytes and looking at signs and symptoms of chronic renal failure. So I'm not about to read the whole thing to you. Again, I just wanted to show you so that you could be aware. All right, so, and then before we're gonna play Jeopardy, but first I want to go through the study guide. All right. Where's the study guide? Where to put it? All right, so I typed this up real quick. It's not that cute, but as long as you know what to study for. So let me zoom. All right, so again, it'll be 100 questions. I will keep, I wasn't gonna put any math, but then people were like, no, the math, please. Oh my God. So, gotta go. Go ahead. Now get away from my desk. Go away. Go over there with that. All right. Okay, 100 questions, 4 select all that apply, and 1 hotspot. We're about to play Jeopardy, so let's see. I honestly think you may want, well, I'm gonna email you the Jeopardy game when this is over. So you'll see, you can go back through it, play it with yourself. I don't know, whatever you want to do. Play it with yourself. Wait till you see this. Wait till you see the Jeopardy game. All right? Wait till you see it's about to be so lit. Oh my God. No, I'm just playing. All right. Potassium. You need to know your electrolytes. I can't stress enough. This is the one test. You need to know these labs. You need to know what's a normal potassium, 3.5 to 5.0. You need to know signs and symptoms of hyper and hypokalemia and things that will cause each one. You need to know treatments. What kind of medication am I going to give? You need to know what KXLate, which is sodium polyestrine, or however you say that word. You need to know furosemide and loop diuretics, what they do to the potassium. Potassium-rich foods, I can't stress enough. You need to know the diet. This exam, there will be a lot of dietary questions. Sodium, potassium, calcium oxalate, and calcium. There's probably at least 10 questions on potassium alone. So a lot of potassium questions. Sodium, there's a good amount of sodium questions as well. It's going to be the same. Only thing is you do need to know a little bit in regards to hypertonic and hypotonic solutions, isotonic solutions, and how they cause fluid to shift in the body. Same thing, signs and symptoms. You need to be familiar with SIADH and aldosterone and what that's going to do to sodium and fluid balance. And then the diet. Phosphorus. The only main thing you need to know, I already told you in this class. Just think, hyper P causes hyper P. Hyperparathyroidism causes hyperphosphatemia, which is going to cause what? Low calcium. Patients with dialysis end up with hyperparathyroidism, end-stage renal disease, or chronic renal failure. They end up with hyperparathyroidism. Their phosphorus is high. That's why they need those phosphorus binders. And then, like I said, the inverse relationship. Calcium. One trick I could tell you, signs and symptoms for low calcium are the same for low magnesium. Signs and symptoms, the positive Chavastex, the Trousseaus, all that. And so if the signs and symptoms for low calcium and low magnesium are the same, what else is going to be the same? High phosphorus. High phosphorus, low magnesium, low calcium, all have the same signs and symptoms, and vice versa. Magnesium, there's several questions on magnesium. The main thing is knowing that excessive magnesium might lead to what? It's gonna lead to severe muscle weakness. So if, say, you're working labor and delivery and a woman's getting IV magnesium, I need to be monitoring them for what? If I have severe muscle weakness, what's the most dangerous thing? Breathing, respiratory depression. If my diaphragm muscle is too relaxed, I can't breathe. So hypermagnesemia is going to lead to respiratory depression. And monitoring, and also knowing what is the reversal for overdose on magnesium. Fluids, you need to know signs and symptoms of excess, signs and symptoms of deficit. So on the break, somebody asked me well, why would fluid excess make my sodium low? Because everything's watered down. So just because I'm hypervolemic, my electrolytes may actually be low. That's where you have that relative loss or relative, because it's not the amount. I didn't lose electrolytes, but I gained so much water that everything's just watered down. Even my blood count, my red blood cells will be low. It's called hemodilution. So the way I explain it, if I have a cup of salt and I add a little bit of water, that's going to be salty as hell. It's going to be concentrated. osmolarity is gonna be high. The more water I keep adding, the more diluted it's gonna be. The same amount of sodium is there, but it's gonna taste like less sodium is there because I've watered it down. So it's the same thing. Just like when you drink some bad Kool-Aid. It's too hypervolemic, ain't enough Kool-Aid, just water. Yeah, same thing. It's watered down Kool-Aid. It's the same packet of Kool-Aid. They just put too much water and certainly not enough sugar. That's right. So specific gravity, you need to know that. Renal disease, you need to know these labs, especially BUN and creatinine. Oh, sorry.
No, you're fine. I'm gonna slide this in here first.
Oh. No, I don't know why they, maybe for PMS. She knows where to come in.
That's, I told her to come in and do this box.
Okay. All right. So yeah, BUN creatinine, you need to know what they are. Diagnostic testing for the kidneys. I'll put them there. I got very specific with you guys. Pyelogram and renal biopsy. So don't cry to me next week when you're like, I didn't even study the pyelogram. I effing told you pyelogram was gonna be on there. I mean, some of the stuff, people are like, I don't understand how I got this wrong. I gave you a study guide. It said, under GI bleed, it said BUN. That damn near was an answer to the question. I gave you a study guide. So don't ask for a study guide and then don't use it. So you need to know those meds, like I already told you. Nephrotoxic agents, renal diet, you need to know that. And you need about signs and symptoms. I'll change that now. All right. Oliguria, need to know what that is. Need to know how chronic renal failure and end-stage renal disease affect electrolytes. Dialysis disequilibrium, common complication of hemodialysis. It's in your book. It's one little paragraph. Read it. Peritoneal dialysis. You need to know about the complications of that. Need to know about, what did I just tell you about preparing the dialysate? That's right. Don't be putting no cold dialysate in my belly. And me all cramped up. All right. Urolithiasis. That's stones. Whether it's nephrolithiasis, whether it's ureterolithiasis, you need to teach a patient about a calcium oxalate restricted diet. It's in your book. You need to look it up. All is in AT. It's in both. ATI, both. You can Google calcium oxalate. I mean, UTIs. You need to know about UTIs, patient education, who's at risk, different types of, is it pre-renal, is it post-renal, all that. Glomerulonephritis, acid base. I put on here, people, 11 questions there will be on acid base. Did everybody get the chance to watch that video? No. Okay, I'm not gonna show it to you guys now. Did we do acid base tic-tac-toe here? We didn't? Okay, so I will do that. Because I don't want to wait. That video is 36 minutes long. And I sent it out and it's posted on Moodle. I think, didn't I send it? Yeah, because you say you watched it. Yeah. The 36-minute, those two videos I sent you will seriously help pass this test, okay? His explanation of acid base is so on point, but to give it to you quickly, respiratory acidosis is caused by increases in CO2. So any disorder that's going to cause me to retain CO2 is going to lead to respiratory acidosis. So what might cause me to retain CO2? Slow breathing, right? So anybody with respiratory depression, slow breathing, slow respirations. If I'm only breathing 4 or 5 breaths per minute, I'm going to end up in respiratory acidosis because I'm not blowing off enough CO2. What else? COPD, lung disease, asthma. Because even though they may get in an asthma, say I have an asthma attack, and you might be breathing fast, but the exchange of the gases in your lungs is not happening effectively. So don't just think, well, when I have an asthma attack, I breathe fast. Okay, yeah, but your lungs at the alveolar level, when we learn about it next week, aren't working the same. So they're not getting rid of CO2 the same way.
Isn't hyperventilating for alcoholism?
Yep, right, but I'm saying, if you have lung disease, your lungs, just because you're hyperventilating, they're gonna be hyperventilating because they got too much CO2 built up. So you teach COPD patients to tripod, lean forward, purse lip, breathe. Why? Because they're able to force out more air, force out more CO2. But hyperventilation, because that's how we get rid of CO2. So if I'm having an anxiety attack, or if I have a ventilator and the respiratory therapist going a little crazy, doing too much, got my settings set up high, and now you got me blowing off too much CO2, that's going to be respiratory alkalosis. So a low CO2 is going to cause a high pH. A high pH is going to cause a low CO2. That's it. As far as alkalosis, it will cause like numbness, tingling, paresthesia. Okay, so someone when they're having, that's why anxiety attacks, people start hyperventilating, and they're like, oh my God, I'm numb, my fingers are numb, my lips, oh my God, I'm gonna hyperventilate some more. No, dude, calm down. You're in respiratory alkalosis. Take this brown paper bag and breathe this CO2 back in. All right, metabolic. Metabolic is going to be from a build up of, well, not build up, a decrease of bicarb. Bicarb is a base. Bicarb neutralizes acids. So, what kind of things are going to cause me to have a low bicarb? Diarrhea. Diarrhea is going to cause me to lose bicarb in my stool. Kidney failure. I'm not going to be able to retain enough bicarb. That's acidosis. That is acidosis. Hypokalemia. Hypokalemia. What happens with hypokalemia? I did that in the slide last week. All the potassium is in the cell, and I need more outside of the cell. So hydrogen is going to go into the cell. Hydrogen, think of hydrochloric acid. Hydrogen is going into the cell. Potassium is going to come out in exchange to get more potassium in my ECF, right? So low potassium is going to cause hydrogen to hide, and it's going to put me at alkalosis, metabolic alkalosis. Low potassium goes with alkalosis, and then the opposite happens. High potassium causes my hydrogen to come out of the cells and put potassium back in the cells. So high potassium goes with acidosis, low potassium goes with alkalosis, both metabolic.
Oh, metabolic, isn't it low pH and low bicarb?
Low pH and low bicarb. Low pH and low bicarb. And if it's metabolic, the bicarb and the pH are moving together. So low pH, low bicarb. So what might cause me to have high bicarb or lose too much acid? Besides, I said hypokalemia shit, but that was making, besides hypokalemia, what else might cause me to be alkalotic? Vomiting, or NG suction. Vomiting or NG suction. Why? I got all that acid in my stomach. Now it's coming up. So that's going to lead to alkalosis. So with acidosis, it's usually kidney failure or diarrhea. Alkalosis, metabolic alkalosis, is usually too much GI suction or vomiting. And then again, the potassium imbalance could go one of two ways. Hypokalemia could cause alkalosis, and hyperkalemia could cause acidosis. That's all and since we didn't do it, I am gonna do tic-tac-toe with you guys. So everybody get a piece of paper out real quick. because this is actually just any old piece of paper will do. Don't worry. Oh, I sure didn't. I gotta put some stuff up here for you guys. My bad. See, I did for Wednesday and Tuesday night, but not for you guys. Also, if you're having a hard time with the fluid and electrolyte, I do recommend, look at that book I sent you guys. Fluid electrolytes made easy. It's much easier to read than lipid guide. Which is good.
No, we're saying it's 500 pages.
We don't gotta read the whole entire book cover to cover. You need to read about the one paragraph about potassium. And 500 pages is probably 200 of practice questions. Exactly. That's your guy's problem. You want to watch a module and hit go, in. So that's why I didn't assign any homework. Because what's the purpose? If all you're doing is just trying to do some stuff to say you did it, what's the point of that? You're not gonna learn anything, just sitting there password, because that's what I do. Give me all these modules to do. So, tic-tac-toe, right? Oh, now I want to use my fancy marker. Does it work? How do I get it to work? Okay, tic-tac-toe, real quick. When I set up tic-tac-toe, this will be real easy for your exam. If you get it. Setting up tic-tac-toe, everybody knows how to play tic-tac-toe, right? Yeah. Okay. All right. So the first row is a given. These are freebies. Okay. Somebody's like, well, you only put 2 in a row. Okay, this is a row 2. Okay, it's free. You get this one free. All right. So that's how you set it up. Normal in the middle. Acidosis on one side, alkalosis on the other side. Doesn't matter what side you put it on. It's gonna work out the same. Up and down. It's all the way to way. You're not gonna get tic-tac-toe diagonal. Only up and down. So, I'm looking at labs. This is kind of small. This patient is, all right, so we got the tic-tac-toe set up. So here's an example, some random question I found online. All right, patient, they're found down, because this is how they ask you the question. They got to give you a 3-sentence paragraph just to give you these numbers. So the patient's found down, they go to ER, they had an ABG done, and these are the results. So if I'm doing tic-tac-toe, I know 7.25 is acidic. So in this, it's less than 7.5, so I would just write pH, because right, 7.35 to 7.45 is normal. Anything less is going to be acid. Anything more is going to be alkalosis, right? All right, so I got that one. What about the CO2? CO2 is 60. I know normal CO2 is 35 to 45. Anything higher is what? Acidosis. And anything lower is alkalosis. Yep. So the CO2 goes here. I already got 3 in a row, so I know my patient has respiratory. The CO2 occurs in the lungs, so I know they have respiratory acidosis. Right? And just to finish, all right, and they usually give you a PO2 because that comes on the labs. It doesn't have anything to do with the acid-base balance, so just ignore that number. It has nothing to do with acid-base balance, but for shits and giggles, a normal is 80 to 100. So don't worry about that. Bicarb, 26. Normal. Only for ATI, ATI's values are 21 to 28. I don't know why they do that. Nowhere else in America is it 21 to 28. It's it's usually 22 to 26. It's a much tighter window. But whatever, for the purpose of these tests, anything greater than 8 or 28 is what? Alkalosis. And is that metabolic or respiratory? Metabolic, good job. And anything less is acidosis. So, not the prettiest hammer, huh?
Their value for test for 21 to 28?
21 to 28 is your ATI exams, yes. Trust me, when you go to NCLEX, all these tests, the number is gonna be so out of whack, it won't matter. The number is gonna be dramatic as hell when you take your NCLEX exam. So, but for the purpose of these exams, 21 to 28, through ATI. So, what's up?
I don't know, I just have a question. So if you have like a lab value of CO2, 32, that'd be osmosis, but the respiratory is like 7.48.
The pH?
Or no, yeah, I'm sorry, the pH.
All right, so, does everybody so far, before we get to her question, everybody get this part?
Yeah.
So, that's when you talk about compensated and uncompensated. So say my patient, this was 7.4, let's say 7.48, right? That's alkalosis, right? That's my pH. All right. And let's say there's CO2, like you said, let's say it's 55. It's high. But then their bicarb is 17. This means they're in what? Metabolic alkalo. I'm sorry, wait, I did that wrong. 29. Let's say it's 29. Don't say 17. Ignore that. Alkalosis. Metabolic alkalosis. First, that's the general underlying condition. No, the pH is what tells me, are they acidic or not? Are you basic or not? I need to know. This person's basic on that.
Whatever the pH is.
The pH is gonna tell me if it's acid or base, and then the CO2 or the bicarb is gonna tell me is it metabolic or respiratory. So this pH, I know it's alkalosis. Obviously, that's not alkalosis. This is. But what happened is my body is gonna always try to maintain homeostasis. So I know, oh, my kidney, or what happened? I don't know. I had a bunch of diarrhea. I had a bunch of vomiting or something, and I retained all this bicarb for some reason. My body is gonna say, all right, kidney's not doing what they're supposed to do. Lungs, start holding on to CO2. Start holding on to CO2 so we can balance ourselves back out. So what this is, partially compensated. My body is trying its best to compensate for this alkalosis. Got it? If this was 7.45, fully compensated. It's still the same other numbers. This is only just barely normal. It's at the toppest end of normal, right? So that's closer to alkalosis. So what happened is I was able to retain enough CO2. I was able to increase my acid while my base was up, fine. I'm gonna meet you where you're at, and I'm gonna increase my acid to get back to 7.35 to 7.45. These numbers are abnormal, but it's at least keeping my body at a normal pH. Does everybody get that? For the test, you don't need to know compensated and uncompensated, okay? And probably not even for NCLEX. You probably don't need to know that level. But if you keep practicing these numbers, now you just be able to look at them and see it, over time, not next week.
I thought this would be metabolic, right?
This one, yeah, because the bicarb side. But you could have respiratory alkalosis.
And that's what the pH means.
It would be the So, all right, let's do some more, because now we're gonna do practice. So everybody get your paper. A piece of paper, any paper, I don't care what paper you use. How do I delete now?
You go to the arrow, wait, look. I was telling you what the Discord is.
On the, yes.
Top of the board, wait, other side, on the paper, on the paper.
On the paper?
Yeah. Oh, wait, shit. Yeah, there you go.
All
That's
right,
the arrow.
this one?
Yeah, eraser, bottom.
Damn, I gotta go through and erase the whole thing?
No, just hit.
Oh, yeah, delete the whole thing. All right, wonderful. All right, so let's do some practice. Do this first one. It's cool. If anybody knows the answer, just hold on. Let me set this up. All right. So we got acid, normal, alkalosis, right? All right. pH 7.53. Alkalosis, right? Oh. pH, right? 44. Normal. CO2. 34. Alkalosis. So what do I got? Metabolic alkalosis. It's that easy. All right. All right, next one.
So if the CO2 was higher than the pH, it would be active respiratory.
No, if the CO2 was low, then it would be respiratory alkalosis. CO2 is an acid.
So.
A pH is a measurement of the acidity.
And so the pH is gonna be, so the pH is both of them. So pH, whatever it is, alkalosis, acidosis, you know what that is. But the PCO2 and HCO3 is whether it's metabolic or respiratory.
Yep, that's it. So this
whichever
next
one's
one, 6.97,
Acidosis.
acidosis, severe acidosis. But you'll see it, happens all the time. CO2 is 60, acidosis. 27, bicarb is normal. So what is this? Respiratory acidosis. It's that easy.
So it's easy once you memorize the. Oh, that's easier than I thought.
What, who said wait? What's up now? Why would it be, the bicarb is normal. It's totally normal. What value are you looking at? ATI says normal is 21 to 28. So if it's 27, that's normal.
Bicarb is respiratory or metabolic.
Bicarb is metabolic. It's controlled by the kidneys. It's metabolic. The kidneys metabolize all type of stuff. That's a metabolic problem.
Since it's 18.
Alright, did I go to that one yet? I'm up there.
Alexa, don't look at the bicarb is solely for metabolic. Don't depend on that to see what the other one is.
This is the question I'm on, the one that's highlighted. So again, keep practicing.
So if bicarb is out of the norm, that means it's metabolic.
Could be, you have to look at the pH, because it could be partially or fully compensated too. The pH is gonna tell me is it acid or base. And then whichever abnormality goes with that pH, it's that problem. It's either respiratory or metabolic, yes. So if the pH is low and the bicarb is low, then I know it's metabolic acidosis. If the pH is high and the bicarb is high, I know it's metabolic alkalosis. If the pH is low and the CO2 is high, CO2 is an acid. So I know that's respiratory acidosis. You really need to watch that 30-minute video I sent you. It will break it down to the most basic of terms. There will be 11 acid-based questions on the exam.
Like that, it's gonna tell us for like, how it's gonna give us like value.
Or it will give you a patient scenario and what values go with that patient. It may give you 4 values to choose from. So you have to know what values go with what. But the easiest way to figure it out, if you figure out this tic-tac-toe, it's easy as that.
So I have a question for your next one. Only the pH is off, the other is considered normal. So.
Oh, you know what? I screwed up because I forgot. You talking about this one?
Yeah.
I was thinking about, because anywhere else in the world is 22 to 26. So I meant, I said 38. Shit. The ATI made up its own range. Shoot. 28 is alkalosis anywhere else in a real hospital setting.
So that would be metabolic alkalosis? Yeah. Metabolic alkalosis?
Oh, how did I? Oh, no. I didn't do, this wasn't the one I messed up. No, it was 28. This is respiratory alkalosis. The CO2 is low. The pH is high. Right? CO2 is low because it's less than 35. And the pH is high. I'm gonna go to that one next, whoever's asking. I hear you. And 28 is normal. According to ATI. There was another one that I thought I messed up, but I must have fixed it. But CO2 is low. CO2 is an acid. It's an acid. So if it's low, I'm basic. I'm not acid. So CO2 is low, pH is high. All right. Next. All right, let me go back to that one. All right. So this one, 7.33 is what? There you go. All right. 42, CO2. Normal. Yes. And what is HCO3? Acid. So it is metabolic acidosis.
Now we feel smarter.
Yeah. Oh, wait till we play Jeopardy, boy. You don't feel like a genius or a retard. I don't know. One or the other. No, I'm just kidding. All right. 7.47. Alkalosis. CO2. Normal. Bicarb. So what is it? Girl, you got it. Yes. Can we get a slow clap? Yes. All right. 7.53. Alkalosis. CO2 44. Normal. Bicarb. Alkalosis. So what is it, Kanisha? Metabolic alkalosis. You guys got it. All right. What about this one? This is a trick question. It's all normal. Normal. This is a normal, healthy human being. I just wanted to see, because some people are like, I think it's metabolic. It's metabolically normal. Just normal. I was just tripping. All right, what about this one? Acidosis. Yes, respiratory acidosis. Everybody got that? The CO2 side, the pH is low. Is anybody, I'm not trying to call anybody out. Does everybody feel okay? Like you got it? I mean, you probably need to keep practicing, but do you have a good idea on how to read ABGs? That's it. You only, if they give you 5 numbers, 6 numbers, because really when you draw an ABG, it has the electrolytes, the hemoglobin, it has other numbers on it. Don't matter. Cause that's what they like to do. They like to just throw all types of random shit in the answer, in the question. All you need to know is the bicarb, the CO2, and the pH. Don't look at the rest. It's bicarb, CO2, pH. So you can Google, if you go on Nurse Sarah, actually, registeredrn.com, whatever it is, she actually has those practice quizzes, and she has one that's like 30 questions of acid base just the values, reading ABG. Yeah, there's plenty on ATI, they're everywhere. All right, so that's acid base, and then finally BPH for the exam. You're gonna need to know the meds. You need to know about finasteride and tamsulosin, and you need to know about a TURP procedure and what taking care of a patient after a TURP. All right. Everybody, you good? We good? All right, it's 2:38. Shit, I don't want to take too much of your time, but we'll see how you feel as things go on. I'm gonna email you the Jeopardy game, but we're gonna play it right now. Hold on before I open up somebody score or something. All right. Oh, I know what I mean. All right, how many people are in this room? We need to split in two groups. So divide yourselves however you want to do that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then 1, 2, 3, 4, 5, 6, 7. I need, all right, so you two will be on that side, you three will be on that side. Your team, you don't gotta move if you don't want to, but we're playing Jeopardy, 2 teams. Oh, never mind. So 9, so 1 person needs to go on this team. You wanna go there, Nick? Okay, so this group is a team, this group is a team. All right. Yep. Oh, she's at the hospital. Oh God, go ahead. Okay. Okay. All right. So then that goes back. Never mind. Dad, Nick, come back over here. Kanisha and them, y'all over here. No, I'm just kidding. Kanisha and them. That'll be the team 2. Kanisha and them. And team 1 will be Soraya and them.
Soraya and them. Yeah, buddy.
All right. All right. The way this is gonna work, this is Jeopardy. It's Jeopardy. So you gotta answer the question like, oh, what is the text? All right. First column is acid-base questions. Title of that category is, are you basic or not? Next 2 are all about electrolytes. They got some electrolytes over here and a little more over here. Number 3 is about fluid imbalances. The next one is about genitourinary problems. So it's what you got going on. And the last one is about your diet. You're gonna put it in your mouth or not. Alright? So with that said, Soraya and Kanisha, pick me a number between 0 and 20.
11.
How do you know?
17 was in my head.
17 was in my head too, so you won. You won. So Kanisha and them, you guys go first. So 1 person from the team will answer the question, but you're on a team so you can help each other. If you can't get the answer or if you get it wrong, then it gets passed to the next team. All right, Kanisha and them, who's going first? Anybody? Y'all want to get it wet? Get it wet for 400. Here we go. Oh, wait, not that one. That's okay, it didn't show you anything. Get out of here. All right, I was getting it on over there and what you got going on. Okay, get it wet, get it wet. There's a shift in fluids from an area of high concentration to low concentration. Low concentration to high concentration. That's right, Kanisha and them. You got your little point. Wait. What? Edit the score. Oh, shit. Hold on. Excuse my French. Y'all so smart. Hold on. Put this up here. No wonder. I was like, what occurred? All right, Kanisha and them. What you picking next? What happened here? What I'm doing? Get out of here. Escape. All right, hold on. This is what I didn't have these problems last. All right. Hold up. What to do? All right, start again. Continue. Here we go. Let's see. Did it work? Oh man. Okay. Hold on. Let me try it again. All right, while I'm going to that, think about what the next question is you're gonna pick. What do you want? What do you think is gonna be so awesome for you? Where the hell I got that from? Here, let's go back. Put it in your mouth? All right. Look, I'll write the score down if they don't want to cooperate. All right, what are you doing next? Hold on, that was done. 200? All right, forget you. See, I know, I'm trying to see why it won't let me give you a score. Oh, I know. Probably because I didn't show the answer.
Are you still recording?
Yeah.
Try to type a 0 into that box again and then hit the plus sign.
Yeah, let's see. Oh, wait, 0. There we go. Who was that? Who was that? Okay, all right. Melissa's so smart, girl. Look at her. Thank God she was here. All right, put it in your mouth, 200. These are full of this electrolyte. Boom. Kanisha and them. They got to get something wrong. All right, who's next? For how much? All right, so this is Pedro. Pedro was at work, found out he got laid off. Then his girlfriend called and was like, you know what? I don't want to be with you anymore, Pedro. Pedro is outside in the parking lot at work having a nervous breakdown, okay? He is having a panic attack right now. What acid-base imbalance do we expect Pedro to have? What is respiratory? Alkalosis. I don't know, get cut off in there, but.
That's so smart.
So we would give him a brown paper bag so he could breathe in some of that CO2. Or if you're in the hospital, you put a non-rebreather mask on the patient so they could breathe some of the CO2 back in. They over here balling, Kanisha and them. Y'all lucky don't worry, I'm broke. I couldn't get any prizes. I just want you to walk up out of here with your head held high, all right, when you win or lose. If you don't win, don't worry. Play the game at home with your kids. All right, what's next? What? 400. Blank magnesemia results in increased nerve excitation, resulting in paresthesia and hyperreflexia. Oh, y'all killing it. They're killing it. They're killing it. All right. After the next question, I'll flip it to the other side. Because clearly Kanisha and them, they trying to get some money up in here today. So I don't know. I don't know if there's any hope for Soraya now. All right. What's next? Which one?
Put it in your mouth. Put it in your mouth for 5,000.
Put it in your mouth for, which one? 1,000. All right, here you go. You done went to Grandma Murtis's house, okay? Grandma Murtis just prepared some lunch. Besides sodium, what cation are these foods rich? Somebody yesterday was like, we from Cuba. We don't know that. What is that? I was like, all right, damn. It's a dark green leafy collard green, okay? It's a collard green. What is calcium? Canned salmon and green leafy vegetables are rich in calcium. All right. Oh, let me put Kanisha and them on the map. All right. All right. Soraya and them. What do you guys want?
What about let's get it wet?
All right. For how much?
For 500.
500. Aside from body weight and vital signs, monitoring or measurement of this can give a good indication of fluid balance. And it is not need to be done by a nurse. That's a hint. It can be delegated to somebody else.
What is skin turner?
Ah. You're not gonna have a CNA assess skin turgor. Output, intake and output, intake and output. Dang, Soraya and them, I try to get y'all a little something. Now go back to Kanisha and them. I can't do that to them. Come on. They already losing so bad. All right. All right. Kanisha and them. Oh wait, did I intake and output? Okay, Kanisha and them. Who's going? Get it wet, 600. D5W is ordered for your patient with 3 days of history of vomiting and diarrhea. This is considered a what? What type of solution? That's right, isotonic. They're getting that paper over there. All right. What's next?
A little more electrolytes, 700.
700. Calcium has a blank relationship with phosphorus, meaning when calcium goes, phosphorus goes.
Inverse? What is inverse? Well, if the calcium is high, the phosphorus is low.
Yep, inverse, high, low, or low, high, however you want to say it. They're inverse relationship. One's always going to be going one direction while the other's going the other direction. All right, I feel bad for Soraya because, man, Soraya comes in here happy. Good morning, everybody. She gets everybody feeling good. Good girl is quiet as ever over here. Carly, Gabby, they're over here. They're ready to answer the question. Kanisha and them, y'all just dog walking their team. I need y'all to calm down over here. Let me give them some time. Let me give them some time to show up. I want everybody to feel good when they leave here. I don't want half the room crying. All right, Soraya and them. Adria, which one are you gonna pick?
Pick something big.
Go big or go home.
1,000 for some electrolytes.
1,000 for some electrolytes. This medication is the antidote for magnesium toxicity. It should be on your exam. Some of these things you might want to write down on your study guide. Anybody? What is calcium gluconate? Yeah. What the better? There you go. There you go. All right. All right. Now they don't have to leave here feeling like losers. All right. What's next?
Get it, Mel. Get it, Mel.
Come on, Mel. Get it wet or something. What you want to do? Come on. Come on, Mel.
Get it wet, Mel.
Which one was some? This one? Alright, alright, alright. I don't know what happened, but your face is coming in for an electrolyte imbalance, probably hypovolemia. What is that? No, this is hypo, I'm telling you, they have hypovolemia. That is a U wave. U-wave. So what is that? T-wave. That's just a T-wave. This is the T-wave, people. If there's an extra one at the end, that's a U-wave. This is the T-wave. Just gonna say that again. This is the T-wave. That's T-wave. All right. I'm just saying, you might want to write some of this stuff down. All right. Oh, I didn't give you the point, did I? What was that? 800? Look.
Professor Carly.
Yes, ma'am.
Is there an absence of the P wave?
Is there what?
Like, is the P wave not there?
Oh, there's P-wave. Oh, actually, you know what? You're right. It's probably so flat, you can't really see it. But the P-wave, that's probably the P-wave, that blue one over there. But yeah, it's so flat. But P, Q, R, S, you don't need to know all this. But this is a T wave, so this will be the one that might be peaked if they had hyperkalemia. And then this extra wave here is a U wave. So yeah. Yeah, there really isn't a very good P wave there. You can't even see it.
Who's picking?
All right. I don't know who's picking on you. Oh wait, let me give y'all that little 800.
All right. Put it in your mouth, 900. Oh yeah. Okay.
All right. Person with this condition should avoid all these items. I can zoom up in.
What's that brown stuff? What's that brown shit?
Hold on. All right, I can tell you, it's peanuts, black tea, spinach, and chocolate. And if I have this, I need to avoid all of these.
Oh, Patrick also.
What y'all got? The answer is urolithiasis. You need to know that calcium oxalate diet. Calcium oxalate. Urolithiasis. So if I have kidney stones or anything, I need to avoid foods that contain calcium oxalate. You need to know that.
So the calcium.
It's in your book. Look up urolithiasis in the ATI book. There's 2 sentences in there. So. All right. Nobody got that point. What was it? That was my okay. I'm gonna just start picking them because I don't want to keep you here all day. Let's just go through these questions and get up out of here. All right. Here's 1,000. A nurse is caring for a 3-year-old. The 3-year-old had 160 mL of urine output over the past 8 hours. Is that good or bad? Why do you think it's bad? For an adult, it's 30 mLs an hour. For a child, you should have a urine output of 1 ml per kilogram per hour. So for this, I need to know how many kilograms does this kid weigh?
I got it.
I mean, not 1 ml, 1 liter per kilogram. 1 liter, yeah, what the hell? A drop of urine? I didn't mean to say that. 1 liter of urine per kilogram. 1 liter of urine per kilogram.
Per hour?
Yeah, per hour. Wait, why am I mixing this up? 1 milliliter per kilogram per hour. 1 milliliter per kilogram per hour. 1 milliliter per kilogram per hour. Because now that I thought about that, I'm like, shit, they need like 30 liters urine. That's a lot. No, 1 milliliter per kilogram per hour. So this kid weighs about 15 some odd kilograms, right? So they need about 15 some odd mLs per hour minimum. They've had 160 in 8 hours. That's 20 mLs an hour average, right? So that's more than 15 point whatever it is, because I didn't do the math, but that's the answer. Continue to monitor them. Their urine output is normal. A child's urine output, 1 milligram per kilogram per hour. But that was an 1,000 question point. That's why it was 1,000 question. 1,000 point question. You know what I mean? All right. All right. Client with end-stage renal disease being treated with peritoneal dialysis. He noticed that the dialysate is clear in color, less than instilled, and he's having a little abdominal pain and nausea, and also noted a 2-pound weight loss since last week. Which one is the symptom to report? Pain and nausea. Pain and nausea. If I'm on dialysis, my issue is fluid overload. So if I lost weight, it's probably because I got dialyzed or something and the weight went down. I want the fluid to come out clear. If it comes out cloudy, then I probably have peritonitis. If I come out cloudy, then there's probably an infection going on in the peritoneal cavity. And then it should, some of that fluid is going to get absorbed and some of it's going to get excreted. So it being a little bit less isn't a big deal. But signs of peritonitis need to be reported immediately. All right, spironolactone. Place patients at risk for what electrolyte imbalance? Yep, hyperkalemia. Hyperkalemia. It's gonna make my potassium too high. Oh yeah, this is a horrible picture, but hey, whatever. It's thirsty. You're gonna see all kinds of crazy shit. All right, these people OD on heroin with a kidney vaccine. This is like a famous picture last year. Something happened. Respiratory acidosis. That's what it was. Because they have respiratory depression. They have overdosed on an opiate. They breathing they lived. Don't worry, they lived. Probably embarrassed as hell, but they lived. Yeah, so they're probably only having 2-3 breaths per minute. They're holding on to CO2. Gonna be respiratory acidosis. Opiates, opioid overdose is gonna put you at risk for respiratory acidosis. I'll get like 5 more and then I'll let you guys get up out of here. This solution would likely be used to treat a patient with a sodium of 148. What type of solution? 158, sorry. What type of solution? Isotonic or what? Hypotonic. If they have a high enough sodium, a hypotonic solution will help balance that out. All right, what's another one? BPH can lead to what type of acute renal failure? Well, renal is kidney. Remember those 3? No. Pre, intra, and post? Post-renal. Post-renal. I have an obstruction after the kidneys. Post-renal. The problem is after the kidneys. It's not in the kidneys. It is up. My prostate isn't in my chest. It's up before. Pre-renal is dehydration, not enough fluid going to the kidneys, or decreased perfusion, not enough blood flow to the kidneys.
So it's causing it.
It's what caused the renal failure? Was it something pre-renal? In the renal, like damage to the kidneys because of diabetes, hypertension, that stuff, or after the kidneys? The prostate is obstructing the flow of urine out of the bladder. So that's post-renal.
Okay.
All right. Intra, what would? Medication. If I got vancomycin and it's destroyed, you start reading, girl. This is my student that told me she didn't read. I don't know what I did. I just didn't read. Oh, you're reading now. You're reading now. I see it. No, I'm just playing. All right. This very simple lab test should be performed on an infant with decreased PO intake and irritability or a confused old person. Urinalysis. All right. Child presents with facial edema, decreased urine output, and hematuria following a strep throat infection. What do you think they have? Glomerulonephritis. Glomerulonephritis. So with glomerulonephritis, these two things should be restricted from their diet. One is an electrolyte. Sodium. And what's the other thing I should restrict? Fluids. Sodium and fluid restriction. But really they'll be on a renal diet too. But when you're thinking of somebody fluid overloaded, you want to keep them away from salt and water, because water is going to go with salt. Hypokalemia places the patient at high risk for toxicity of what drug? Antiarrhythmic drug. What antiarrhythmic drug? 5 low potassium, I should hold what medicine? Starts with a D. Digoxin. Digitalis, digoxin. Hypokalemia places patient. If a patient takes digoxin, we need to know their potassium level. What about these fluids should be administered cautiously. Now this one's hard. What? Yeah, it's if it has sodium, so what? Hypertonic. Hypertonic. You're right. Sodium. Hyponatremia could place you at risk for cerebral edema. But also administering hypertonic fluids can still, if you administer them too fast, I'm sorry, not hypo. It should have been hypotonic. Sorry. Hypotonic fluids can lead to cerebral edema because just like hyponatremia, the excess water is going to go where? Inside the cells. My cerebrum, my tissues are made of cells. So if I have cellular edema, yeah. But you can read. Don't worry, this one was too hard for this. This gets out your mind. Move on. That's for neurologists. All right. Vitamin D deficiency go place at risk for what? Calcium. You didn't have to go to nursing school to know that. All right. Lupus, pyelonephritis, and poison can lead to what type of kidney failure, Mel? Huh? Not just chronic, but what? Intrarenal, intrinsic. It's happening. The damage is happening in the kidney. All right, and then I do like 2 more diets. I'll let y'all out. I know y'all want to get out of here. Nobody cares anymore. This melon is rich in what? Potassium, cantaloupe. Oops, sorry, but you got it right. Oh, this is my favorite one. This is my favorite one. It's so funny. I'm so funny. All right, so your patient has serum potassium of 5.5. She wants to know if she can have this little salad for lunch. That's right. That's right. Tell him. Tell him. Hell no. No. That's my man right there. He's so funny. My son gets tired of hearing it. That's what she's gonna say when she come out here with them potassium-rich avocados. No, ma'am. Answer is no. Oh, we already did that one. All right. Anybody have any questions before next? Oh, here's one. Patient renal diet. They're trying to figure out what's the best size. I'm on a renal diet. What should I get? Oh, those are sweet potatoes, not carrots. Sorry, with raisins, you know. Rice. Potatoes are rich in potassium. Potassium and potatoes. All right. Potatoes are rich in potassium. So you'll see in the hospital when everyone else is getting a tray with any type of potato product on it, the renal patients are going to have rice usually. Dried apricots, sweet potatoes, raisins, all that. It's rich in potassium. Yeah, but I recommend you keep it.
Are you gonna give me the? I didn't post it on Little. You're gonna give me the grade for it?
Just take pictures of it and post it before Friday, or email me. I want you to keep these. I want you to do the worksheet. The reason I made it mandatory was because it's developed a really good study guide, and I wanted everyone to do it. But turn it in by Friday, because I want you to use it by first. I want to make sure you're doing it in study. The worksheet, if you didn't do it.
So I turned it into the ATI thing. I turned it to the ATI homework that was due.
Oh, that's why I know.
So I returned it in, but.
That's fine. Well, you can email it, but the main reason I gave you that one assignment is because, it's such a good study guide for fluids electric. Yeah, okay, you can take the picture.
You're gonna unlock prep you?
You can email it, whatever pictures. Oh, yeah, I'm gonna unlock prep you now. Remember, week after next is the reflective paper. I don't care about APA format, but it needs to be one page. I'm about to send an email anyway, but I'll unlock prep for you now. What else? Anybody? I'm right now gonna post it and email it, cause I was in the middle of doing that, and I'm emailing this game. You're welcome. Have a good one. You're welcome. Oh, I don't care. I'm gonna be sitting here first thing.